Ready, Rob. Right, I think we're on.
Okay, good morning everyone and welcome to the meeting of Adults and Community Wellbeing Scrutiny Committee. Before we begin, for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, assemble in the car park at the front of the building and wait further notice. I would just like to say, in reference to face masks, at this point in time, it is a preference whether you want to wear them or not wear them, as there is no further instructions as at present in terms of what we do in this chamber. Councillor Lee.
Can I ask that it be noted for the record, please, that I asked that everybody in here wore a mask for safety reasons, and I would ask that going forward for council meetings that it's risk assessed if we need to be wearing masks or not. Thank you, and I'd like that on the record, please. Thank you.
Thank you. I would just say, with all the windows open up there, it's nearly like being outside in here, but
I was just going to say, we do have risk assessments. I'm happy to circulate that to the committee afterwards, if that's helpful.
Yeah, it's not having a go at the officers. To me, it's common sense. With what's going on at the moment, it's absolutely common sense, and it's really off-putting to come to a meeting and find that you can either. Can I ask that this be minuted? That I'm either in a meeting taking a risk,
Karen,
or
it's
not.
Also down to how government wants to offer its guidance in the future going forward.
Can I say as well, actually, it would be courteous and polite to let me finish and then have your say afterwards.
Okay. I would like to welcome Councillor Liz Sneed, Executive Support Councillor for Adult Care and Public Health. Welcome, Liz. Nice to see you here. Councillor Colin Matthews, I'm not sure whether he's online or not online. Yes. He's online, so Executive Support.
Hello, Hugo. Thank you.
Morning, Colin. And I'd welcome Glenn Garrard, our Executive Director of Adult Care and Community Wellbeing. Other participants will be introduced when we reach their item or when they first speak. The meeting is being streamed in the usual way. So I'll start the meeting. Apologies for absence, please, Emily.
Thank you, Chairman. We've received apologies from Councillor Young and Councillor Carter, who will be attending via Microsoft Teams.
Thank you. Declarations of members' interests. If any members have any interest to declare it or they come across an interest during the agenda, please let us know. Thank you. I'll progress to the minutes of the 20th of October 2021. Can we confirm that the minutes of the meeting on the 20th of October 2021 as a correct record? Can I have a proposer and a seconder, please? Proposed by Councillor Rob Kendrick. Seconded?
Seconded.
Thank you. Okay, announcements by the Chairman, Executive Councillors and Executive Director. First off, I would just like to just really reflect on Bob Adams, who used to be part of this committee, and I wish Bob's family all the best. Bob was very good councillor. He was well thought of, highly regarded, and very dedicated. And it's such a sad loss to see him go. And I think everybody in this committee would endorse those views and feelings. So sorry to see you go, Bob. The working group on free sugars, as reported on page 93 of the agenda, the working group on free sugars met on the 11th of November. Our next meeting is planned for the 17th of December. We have found that diets, and in particular sugar content in foods, is a very complex topic and confusing topic. I think one of the key things in that people are given advice, for example, by health professionals such as GPs, about managing their intake of sugary foods, but more is being drafted up on this approach for our next meeting. I'm also, just on that, we will send round the minutes of that meeting, as we're trying to, in a sense, thrash out the sort of what I call the bare bones of actually what we want to achieve, because the topic in its own right is actually quite a beast, and therefore we need to be sure that we can actually do something in terms of the council and actually maybe get an outcome rather than sort of get swallowed up in the sugar mountain itself. So, and I think what we'll do is pass the notes round, and it might be that what we've come to the conclusion is that we perhaps will need more people to join, perhaps from outside in certain areas, and so we'll just get it sort of shaped up a bit, and then we'll come back to the committee for a bit more discussion. Councillor Marianne Overton.
Thank you very much. Sorry, I wasn't at that meeting. It sounded like a very good one. We have done quite a lot of work on this nationally, which you've probably picked up on through the Local Government Association, and then lobbied to get the sugar tax, which was in part which was successful. So, and we did find that it's the legislation that in the end made the huge difference. You know, for all the nudging that you do, in the end, it was the whacking legislation that comes in and has a really big impact. So I'm really keen to support the work on that, and thank you for making a start on something that's important to our residents.
Thank you. I think one of the things with the sugar tax, it's actually in effect, the downside is it's industry really driven. So it's actually the food manufacturer pays for the bulk of the sugar tax. And that has its there are complications around that as well, but further works will happen. While dabbling in the world of sugar, I came across a NHS Futures website on health management, and I posted a blog on there, which actually has sort of got quite a good response back, hasn't it, Simon? And about sort of things that people are doing in different areas within the NHS and public and local government. And so we're sort of compiling that. But I joined one of their meetings for Lincolnshire, where we are looking at various aspects of improving people's health, thinking out of the boundaries and out the box, and how we can sort of make real changes. And one of the sort of underlying themes of a lot of the issues that were sort of impacting and bringing people into the world of the NHS or mental health was actually social isolation and social deprivation. And I sort of went off to Leeds University, but online, and actually they've done quite a lot of work on social isolation and how to contact people through COVID. And I think that if people are left on their own 24/7, it doesn't do their mental well-being any good. Ironic that we are talking about mental health today, but one of the things that we've got is we have a social isolation strategy here at LCC, and that was in effect set up about 2 years ago, I think said Glenn. And so that paper we're going to circulate round the committee with a view that let's have a look, have a bit of a research, see if there's anything that maybe might want to take a bit further as a working group to see if actually we can do something digitally or connect some way and support these people, because the impact is that they end up in the NHS or LPFT because of the issues that are from the back of their social isolation. That's me. Done. Liz, any? Yeah, brilliant. Yeah, no, that's brilliant. No, that's sensible. So thank you. Colin?
No. Hello, nothing from us. I'm engaging with Lucy and Justin on some issues in my local area, but interestingly, those issues relating to mental health and the outcomes of poor response to mental health, I think, are echoed throughout the county. So quite an interesting thread developing, but nothing to actually report other than that, like you and Sugars, we're looking at it.
Oh, that's good, Colin. I have heard some of the work that you're doing, and it sounds very encouraging. And I think now we've got to the point that the officers have got to look further and dive a bit deeper into it and see what comes out from the officers now. So good work there. So Wendy Bucket's online.
Yes, I am here, Hugo. I thought you was ignoring me, but I don't think you'd possibly do that. Yeah, I'd just like to offer my condolences for Bob. He was a lovely guy. Known him for 5 years since I joined the county council, and really sad to have lost him, and especially off this committee as well. He did excellent work, bless him. We're just waiting for the white papers to come out from government now for the social care reforms, what we're going to get from government. So hopefully, fingers crossed and toes crossed, that we get a good settlement. And then just carers are still struggling. So, we've all got to help. We're encouraging families and friends, if they can help. At the moment, that's what we're doing. And obviously, you've just mentioned the mental health. Officers are working on that. I'm also working with John Turner as well, and Glenn. So we are looking at everything there, and obviously Sarah's here today. So yeah, that's all from me.
Brilliant. Thank you very much. Glenn?
Thank you, Chair. It's my understanding that the government intends to announce and publish today the Social Care Reform White Paper. It'll be titled People at the Heart of Care. And I'm sure that with your support and the portfolio holders' support, this scrutiny committee will be interested in what that has to say and its implications for Lincolnshire. Thank you, Chair.
Brilliant. Thank you very much. Okay, so we will therefore go on to item 5, the overview of adult mental health services in Lincolnshire. For this, we've got Sarah Connery, Chief Executive of Lincolnshire Partnership NHS Foundation Trust, and Justin Hackney, Assistant Director of Specialist Services for LCC. So Justin's in person, and Sarah, I believe, is online. And there's going to be a PowerPoint presentation.
Morning, everybody.
Morning.
Hopefully, hi, you can hear me okay then, thank you. Simon's going to drive the slides this morning, so thank you for that, Simon. If you just go to the first slide, please. So thank you for the introduction, and thank you for your time this morning. So I'm Sarah Connery, I'm the Chief Executive of Lincolnshire Partnership NHS Foundation Trust, and I'm pleased that myself and Justin can be here today. Just to start off with really a bit of an introduction to the Trust and the services we provide. I will assume that the slides have been read so that there's some sort of time at the end for challenging questions, and more than happy to attend a future committee to talk about anything in terms of a deep dive or any area that you wish to have some more information on. So I'm just going to do some slides and then I'll hand over to Justin to talk about some of the partnership work that we've been working on. So this slide here just basically gives a bit of a flavour for the size of LPFT in the county. Just want to make the point that we are a membership organisation. We're a foundation trust, so we have 10,000 members of the public who are members of our trust. And we work to a governor model, so we have a council of governors who help shape the strategy of the trust and hold us to account for delivering the ambitions for mental health, learning disabilities and autism in the county. So next slide, please. So we structure our services around 4 divisions. We have adult inpatient, adult community, specialist services and older adults, and children and young people sits within the specialist division. Just to say that we do offer the full range of services from mild to moderate depression and anxiety. So that's our steps to change, improving access to psychological therapy services, all the way through to low secure services for those who are acutely unwell and deemed a risk to themselves or others. We also work really closely with our East Midlands colleagues around a Mental Health Learning Disabilities Alliance. So we don't have the provision for high secure beds, for example, but we do work really closely, for example, with Notts Healthcare, who provide medium and high secure beds on our behalf. Next slide, please. So again, this is our specialist and older adult service. I just want to make the point that we don't just provide mental health services. So we do provide social care functions as well, which Justin will talk a little bit more about. Sexual assault services, for example, as well, and neuropsychology. So working with our colleagues in ULHT around cancer pathways and diabetes pathways, for example. Next slide, please. Just a little bit about our COVID-19 response and recovery, to say that we were fully open for all intents and purposes, and we actually moved some services from 5-day to 7-day-a-week working to ensure that we were providing services for those who needed us when they needed us. The only area where we weren't able to provide full service was autism diagnosis, because of the nature of how you have to apply those assessments. And I'll come on to that in a little while. But there's just some bullet points there in terms of how we have adapted our methods of delivery to make sure that we were responsive. Next slide, please. The vision for the Trust is to support people to live well in their communities, and we are a Trust that likes to embrace innovation. And there's just some graphics there that show how we've put that into action. So even through COVID, we've continued to push our services to more robust community provision as opposed to inpatient provision. Some of this is driven by workforce. It's something that every single mental health trust in the country is suffering with, in terms of making sure that we've got the right workforce to deliver the services, particularly around qualified nursing and consultant psychiatry vacancies as well. So we're trying to do everything that we can, international recruitment, for example, to make sure that we are attracting people into Lincolnshire, and importantly, once we've got them, making sure that we retain them as part of our very valued workforce. We have, over the past few years, closed wards. So we closed Rochford out in Boston, which wasn't fit for purpose. It was a first floor ward with a lift. There was no access to fresh air for our older adults on that ward. And what we've done instead is put in a really robust community provision model instead. And you can see there, for example, reducing hospital admissions by 92%. What we've done at the same time as this is make sure that people are well supported in the community, and carers as well. So we've invested a lot in carers champions at the Trust to make sure that families are supported as much as the service user, which is something that Councillor Bowkett's just touched on there. So we always have to have an eye on the carers and families, as well as the service users who are receiving the treatment. An important response for us through COVID was the introduction of the mental health support lines. There's one for adults and one for children and young people. We're also looking at progressing a text service as well. Not everybody wants to pick up the phone and have a conversation about their mental well-being. And for people who are deaf or autistic, it just doesn't fit right. So we want to make sure that all our services are as inclusive as possible. Next slide, please. A key focus for us at the minute is community mental health transformation. So we were successful as a county. It was a county bid to be one of 12 early implementer sites in England. And this is effectively the biggest investment in mental health services for a whole generation. And we've kicked off the implementation in Boston, Gainsborough, Grantham and Lincoln, working with our GP colleagues in terms of the areas that needed focus to start with, to pilot, to learn. And then we're going for a full rollout across the county. So this isn't just about expanding where we don't have services, for example, personality disorder services in the county, but this is about freeing up capacity of GPs through integrated place-based teams to ensure that people don't fall between the gaps of primary care and secondary mental health care, that some people need that, as the chair mentioned earlier, that social connection, social prescribing, peer support and community connection. to make sure that they're being supported without necessarily having to go on a community mental health team caseload and end up on a waiting list for 18 weeks to see somebody. So it's really about bridging that gap. Aligned with this is the investment in the nightlight cafes, which are sort of crisis cafes. At the minute, they're very much focused in Lincoln, but we've learned from the model and we're now rolling that out, particularly on the East Coast, where we feel that there is a little bit of a lack of community asset in that area. And we're hoping that they will be open before Christmas this year as part of our sort of winter pressures response. Next slide, please. Just as a bit of a positive, we've been working really hard to try and get some capital investment in Lincolnshire. It's not suitable for people who are suffering with a mental illness to receive care in a dormitory ward accommodation with nothing but a curtain between them and the person in the bed next to them. It's become more and more apparent through COVID and trying to keep people socially distanced through infection prevention and control measures. It's just not good enough. So we're replacing our 3 inpatient acute wards, 2 in Lincoln and 1 at Boston. And for anybody who's been on the Lincoln County site lately, around where Francis Willis Unit and Peter Hodgkinson Centre, you'll see that we've got the steel frames already up. So we're really motoring on with that. The 2 wards at Peter Hodgkinson Centre due to open early 2023. The Boston ward, a bit more complicated. It's on a floodplain, for example, and also the impact of COVID on being able to source materials and design intelligence, for example, means that one will be March 2024. I really want to make the point that we've used experts by experience in designing these wards. So we've had 10 people who have been on our wards to input to make sure that design is fit for purpose. Next slide, please. We've been tracking really carefully our demand and capacity through COVID. And these are the services where we've seen significant and prolonged increase in demand. We do have sort of a response plan for each of these, whether that be amending processes or getting additional investment, importantly. As I mentioned earlier, recruiting the workforce is our biggest risk and our biggest challenge. So we're looking at new models, for example, to be able to make sure we've got that capacity. Children and young people, a significant concern of mine, but we have got a really robust crisis service, which a lot of other counties don't have. So we are actually the lowest admitter for children and young people, tier 4 beds in the whole of the region, which is something we're quite proud of because these children need to be at home with their families, being supported in their community, rather than becoming a career inpatient. Next slide, please. Sorry, I'll just have to have a little drink. So just as a segue to Justin's slide, I wanted to just point your attention to the system working that we're doing. So we have a mental health, learning disabilities and autism partnership group with a read across to Children and Young People's Transformation Board. And these are all the partners who are represented on that group. It doesn't have any statutory function at present, it's just a point of connection, but you can see some of the working groups that we've got that feed in as a point of connection and escalation. The Prevention Concordat, for example, the work that we're doing with the public health team and the police around suicide prevention and self-harm. It's really coming together. We've obviously got a lot more to do, but we're having the right conversations together as a system. So I'll stop there and hand over to Justin, if that's okay at this point. Thank you.
Thank you.
Thanks, Sarah. So the committee will recall, hopefully, that last time I attended, I talked around Section 75 agreements and that they really help us in terms of being able to integrate care services for people so that they get a much more joined up service. So this is another example of where we're using Section 75 arrangements, but rather than the County Council being the lead commissioner and providing the integrated assessment and care management function, what we actually do in this circumstance is we actually delegate responsibilities to LPFT, and they're able to then coordinate services in a more joined up way for adults with mental illness aged 18 to 64, who are eligible for adult social care. So through that agreement, the main core function really is the assessment and care management function that we delegate, and that LPFT provide those functions on our behalf. But then we work jointly in terms of commissioning services, so for example residential care, and also facilitating personal budgets and direct payments as well. We also have some other services that we facilitate through the Section 75 agreement, and they include best interest assessments to help us with our deprivation of liberty arrangements. And also at the minute we also LPFT help by providing the daytime AMP service. So when people need a mental health act assessment and potentially admission to mental health inpatient care, then the AMPs will work with Section 12 doctors to organise that. So that's really, you know, another good example of how we integrate services really, and how, because LPFT are also the predominant provider of mental health, clinical mental health services, secondary mental health services in Lincolnshire. You know, the people who are eligible for adult social care are also often eligible for secondary mental health services. So because the teams are all employed in one organisation, they can coordinate those services in a much more joined up way. So in terms of that, I mean, our Section 75 arrangements, as I've said previously, have worked very effectively in terms of, you know, joining up services for the people we support, but also delivering good value for money as well. Over recent years, though, we have started to see that actually the complexity of some of the people that we are supporting is increasing, because there has been a national push really to speed up the throughput of inpatients through mental health inpatient provision. Therefore, you know, programs like Transforming Care, there are a lot more people supported in the community now than where previously they were supported, and often inappropriately, in mental health inpatient care. So from a community perspective, we are supporting more and more people with complex needs, and also, as Sarah mentioned, demand overall is increasing as well. So this is a little bit of a future focus really in terms of some of our joint working. So I'm currently working with Lincolnshire Clinical Commissioning Group and LPFT, and we're looking at and wanting to propose going forward. So this is likely to be an item that comes to this committee in the next financial year at some point, with a formal proposal around this. But to actually look at developing a dedicated Section 75 arrangement for people with complex needs. And by complex needs, we are predominantly talking around the Transforming Care cohort in Lincolnshire, and other people have been discharged from mental health inpatient care or at risk of admission, and with gross costs of care above £1,500 a week. And we think in particular that actually by integrating the assessment and care management arrangements for that cohort of adults, then we're going to get much better outcomes for people, because currently it is fragmented across a number of different assessment and care management teams in Lincolnshire. And that actually aligned to that, having the CCG host a pool budget and to be able to commission the care for those people also offers the opportunity for the CCG to commission wraparound community mental health support in addition to the social care that we commission as well. So that's just a highlight of some of our future intentions around joint commissioning, and one that I'm personally really excited about. I think it will be treading new ground nationally in terms of this route, and you know, most importantly, it will deliver better outcomes for people. I'm positive of that. Aligned to this as well is a joint accommodation strategy group that we formed, and I chair that group. Again, it's partnership working between the CCG, LPFT and adult care. And what we identified is that all three organisations were having separate conversations with the market, the independent sector market, and also district council housing leads as well. And partners were getting mixed messages about what as a system we actually needed. So as a group, we're working on a model of 4 different levels of dependency, and we've developed a programme where now we are developing community housing options, as well as developing different approaches to how we commission residential care as well. So again, it's just a flavour really of how, you know, we're working in partnership with our health colleagues in Lincolnshire to get better outcomes. So I'll pause there, and happy to take questions to Sarah or myself on our presentation.
Okay, thank you. Councillor Liz Sneed. Now you are.
Okay. So, Justin, thank you. I'm interested in, have we always provided quite so much support for veterans? Is this quite new? Obviously, I'm aware of what the Royal British Legion do, but I'm interested in that we are upping our game with veterans. It seems very positive as they have so many issues, and we know many of them come to us with their issues. Have we always done this much, or is this quite a recent development? Thank you.
No, we have supported veterans for a while now, and there is a related Concordat that we're signed up to as well. I think I'll let Sarah maybe speak more around the mental health service support around that. Mm-hmm. I mean, what I shared with yourself the other day, Councillor Sneed in particular, was around this was, you know, our day services, how we're now outreaching to the wider community. Right. What we wanted to do is use our day services buildings to invite veterans in, but then also linking them into other services. Mm-hmm. So carer support services, other community services, awareness of mental health services. Mm-hmm. I think that's a really good example of, you know, how we're not just providing day support and day opportunities to service users. We are looking at engaging with the wider community now, including veterans. So, Sarah, did you want to come in at all in terms of the LPFT offer?
Yeah, if I may. So I think where we're seeing a bit of a sea change, it's a really good question, is around the commissioning of those services. So previously it's been held regionally by NHS England, but we're moving to a model of provider collaborative. So LPFT actually runs that provider collaborative on behalf of the East Midlands. So we've had additional investment as a result of that, and it's a lot more patient focused in terms of making sure that the pathways are aligning to the other pathways in the system as well on a regional footprint. So yeah, it's early days because we only took the contract on October last year, but it's already seen some benefits. We're getting some really good feedback. That was all. Thank you.
Thank you for that. Very useful, and I think it's a really good way forward. Thank you.
Thank you. I've got Wendy next.
Thank you. And mine's it's not a question because obviously I'm working with Sarah and Justin with this transformation programme, and I'm so excited. I mean, I haven't just started doing this. Before I became adult for adults and public health, I was working alongside Justin when I first came on county council. Anybody who knows me, mental health is my passion. It has been for a long time. I have a close member who has been very seriously mentally ill in the past, as Sarah and Justin know, and lots of people know. I don't keep it a secret. So community mental health crisis, the new patient environment at the wards. Actually, I'm going with Sarah on Friday to see Ward 12. It is all in my heart and very close to it. So I'm really excited about these prospects of the changes that we're going to make. Sarah and Justin and I are determined we're going to make change, and we will see change, because we can't go on like this. We need to get to all our residents before they get to that crisis point. We need to have access there in the community. We've got plans ahead, whether that's working with the doctors, our PCNs, whether that's working with the new community cafes, which are excellent news. But it's all exciting, and it's going to be exciting for our residents, because at the end of the day, it's their care, their mental health, and you know, we just need to help them, and we are doing. So I'm really, really excited about this. Thank you, Hugo.
Thank you. Colin, you wanted to come in?
I did, Hugo. Thank you very much. And it's very pleasing, just follow up what Wendy's just said, to hear about action. And Sarah, I loved the phrase, especially on the East Coast. Thank you very much indeed. My question is, I'd really like to dig a little deeper, because it's clear that there is an increased presence. Some of it's tangible and some of it's being advertised for future appointments, and some of it's on the internet. But one of the really interesting projects is a coffee morning for men that's advertised as a Zoom meeting on Wednesday mornings. And I'm not sure if the Zoom meeting is going to go down as well as a coffee morning on a Wednesday morning in a building that people might turn up to and at least get a coffee. So please, can we keep pushing for face-to-face presence? But more importantly, can I ask you to dig a little deeper and let me know what is on the ground, what boots are on the ground at the moment, because I am having great difficulty locally travelling back from the ground to find the points of contact, but I'm also having difficulty travelling forward from above through the funding agency to find the points. And I simply don't know who to ask to say who's going to be in that building on a Wednesday, who's going to be there on a Friday, who's running that internet cafe on a Wednesday morning. Clearly I'm contradicting myself there, because we know it's Shine, but it's that joining up that I'm really struggling with. And I'm fairly competent. Well, no, I'll deny that. I'm not very competent, but I'm like a lot of people. I think we need some more clarity about who's doing what for when and how.
Okay. Would it be helpful?
Sorry, Sarah, I'm pleased. That sounds really mealy-mouthed. I'm pleased, but more clarity, please.
Okay, would it be helpful if we had a get together offline and just to explore that a little bit further? Would that be helpful, Councillor Matthews?
It would be very helpful. Thank you very much.
I'll get my office to reach out. Thank you.
Thank you very much. Okay, bye.
What you've highlighted,
Can I just Hugo, can I just come back here a second, please? Because we are, Colin, this is what we're doing. This is what we're trying to do. We're trying to map out all these services along the East Coast, not only the East Coast, but all over the county. And we are working with Sarah, we're working with John Turner, we're working with district councils, we're working with the county council, so we can collate all these groups, all this, whether we need more there, whether we don't need that there. And that is all the work that we are going to be doing from now on forward. So we will be keeping you informed, Colin, and some of it you'll be helping with. So it's all in hand, please believe me.
Wendy, I believe you, and I believe Sarah. All I'm saying is at the moment, I'm in the dark about these things, other than knowing that stuff is happening and I'm seeing stuff falling. And I would like to help, and I would like to be able to join it up as if I were a member of the public and understand it. So yes, I have privilege in that I've got access to you. I'm not sure if what's going on is fully available to the public in a layperson accessible format. That's all.
Right. Okay. Yeah. On that note.
But I'm pleased. It's all right. It's good. I'm smiling.
On that note, I think we've got to be careful we don't end up in a Teams meeting in the council chamber. But the point is, Colin, is as you say, it does need to be joined up, and as Wendy and Sarah have said, that's their game plan. So I think, and as you've highlighted how complicated it is, and it is a challenge, and but at least both Wendy and Sarah have got that as a priority to start to join up to make sure that these services are connected. So on that note, I've got Karen next.
Thank you. First of all, I'd like to say thank you for such a comprehensive report. It's And it's good to see people heading this that have clearly got a passion for it, because I think in the past mental health services have been a bit of a Cinderella service, and it's good to know that there are people heading this that will fight for decent provision. I've got some questions. First of all, I completely agree with Councillor Matthews' comment about important to have a face-to-face presence. I think he's absolutely right about that, and I'd support that. Going back to the Section 75 agreement, again, I agree. I understand the rationale for that, why you'd have that, but I wanted to ask, obviously people put so much in and get so much out. Is there a limit? You know, if you put so much money into commission services, is there a limit as to how much you can spend? Are the spending limits in place with regard to that? And just going back, because I did want to ask Sarah some questions, but I didn't want to interrupt. So the things I wanted to ask Sarah, first of all, can you tell us more about the rate of vacancies for staff within mental health services, doctors and nurses and other staff, you know, what we're looking for in general? How many staff are we missing? Because I know how dire it is in adult care, and I wondered if that's mirrored within mental health care as well. And the last thing really, how easy is it for people with mental health problems to access the community support that you talk about via the GP? Because I know this is a by the by, but this morning I spent an hour on the phone trying to get through to my GP, and I gave in the end because they weren't answering. They seriously weren't, and hanging up. And I actually went in person over there and got an appointment. Now, if I was someone with a mental health need that wanted an appointment, they wouldn't do that. They'd just give up. So are there sort of things up in, is there a direct number? Is it advertised in the surgery or on the website or anything like that? Or is it that torturous process that I've gone through this morning trying to get through a GP, which is incredibly difficult? Thank you.
Thank you. Should I pick up the first question, Sarah, and then you pass on to yourself in terms of picking up the secondary mental health elements?
Yeah.
I can chip in as well there if that's okay. But, so in terms of the Section 75, pretty much they are all tailored in different ways. But in terms of the LPFT LCC Section 75, then really the money that's put into that is all county council's funding, because LPFT are delivering our statutory functions on our behalf. So, whereas the learning disability Section 75, there's more of a pool budget approach, and the CCGs will put in some funding and we'll put in there. But the way it's always calculated is there to ensure that there is funding there to be able to pay for the care and support that's needed. So does that answer your question in terms of that? Yeah, but each one will be tailored in different ways, and we will, if they're pool budgets, then we'll have associated sort of agreements between the organisations about who puts in what.
Yeah, I think what I was trying to say was, are the waiting lists because there isn't enough funding going in? That was the basic thing. I understand it's a lot more complex than that.
So we have no one waiting for adult, so waiting lists for adult social care in terms of the LPFT. I think a lot of the waiting lists are more in relation to secondary mental health services. But again, I think that's, Sarah can talk about that, but the demand outstrips supply. So, but I was really pleased to hear your point around fighting the corner for mental health services. And I think as a system, we've done really well at that. Mental health services does really need a lot more investment. But we were in Lincolnshire one of the sort of people at the front of the queue in terms of getting the NHS allocations to develop our local community mental health services. And I suppose that's coming on to the points that you were raising for Sarah, really, that it's a jigsaw puzzle, but the jigsaw puzzle is still being put together at the moment, and that not all of the community mental health identity is at the primary care network level yet. It's emerging, but there's much more work to be done, and there's further investment to be made, really. So I think I'll pass on to Sarah, but it's work in progress in terms of building that jigsaw puzzle at the moment.
Thank you, Justin. Yeah, really great question. So in response to the questions about the vacancy rate, so we're running at around 20% for our qualified nursing, which is getting into triple figures. It'll be different in each service, but just to give you a flavour, so sort of a fifth of our budgeted establishments at the minute are being filled by bank and agency. For medical, at the minute, it's just over 20%. So it's sort of 23%, I believe, from the last performance report for medical staffing. Hence why we're looking at international recruitment. We're working across the East Midlands Alliance to talk about shared rotation posts as well, because what tends to happen is sometimes another trust will just put out an advert and put a recruitment and retention premium on it. So the staff member goes and you end up in, prices just keep escalating, and, money is tight. So we can't afford just to keep increasing the recruitment and retention premium to try and take each other's staff off each other. So we're trying to work more as a alliance around ensuring that every county's got a sustainable workforce. Back to Justin's point about the waiting list. So for community services, we work to an 18-week target. That's the national target for community mental health services, hence, which is a long time, hence why we need the community transformation work to help provide support either while you're waiting, or you don't actually need a community mental health team. Your need is much more lower level. It's about social isolation. So that's why it's such an important piece of transformation, and a great news story for Lincolnshire that we were one of the early adopters. In terms of your question about accessibility, it's something that we're putting more resource in. We've got the mental helplines. We put it out on social media. We're putting it out there in the media. Maybe perhaps it's still not getting through.
If they're actually in the GP surgeries and on the GP web, because there'll be people who don't go on the internet, won't they?
Absolutely. So we're working through CCG comms to make sure that the posters are there in reception, that the GPs are referring people to that mental health line, and we just keep saying it, and hopefully it will sink in and people will be aware. So GP receptionists should be making sure that people are aware of these telephone numbers. And the beauty in the mental helpline is if people just want to talk to somebody, it's there, but it's also part of our escalation process. So if there's somebody who is really poorly and they need to be accessing crisis services, then it's an automatic triage to crisis. So it's really sort of hardwired in as well. But there is more to do, and we've allocated some funding through our winter precious money to make sure that we're really getting out there, again, particularly on the East Coast as well. And working with district council colleagues, for example, if we can get it on the side of bin lorries, to really get it out there. I hope that answers your questions.
Yes, thank you.
Thank you.
Excellent, thank you. Andrew?
Oh, thank you. I've got a question for Sarah, please. In one of the slides, you mentioned about investment in voluntary and community groups. I chair a village hall, and I know how much work goes on there to counter social isolation, which keeps being mentioned this morning. So I'd just like a bit more information on the sort of voluntary and community groups that you support. Thank you.
Thank you. So we work with the Shine Network as sort of the umbrella for voluntary and charitable organisations within Lincolnshire. And there is a managed care network process where voluntary sector groups can bid for funding in terms of accessing that funding stream. And part of the community transformation is about bolstering that, because when we looked at the social return on investment of that money, it was, it's £300,000. I think it was something like a 10-to-1 return on investment from those, grassroots social investments. So I think we're on, Justin might want to add a little bit more about the managed care network work, but wave 11, I think we're on now in terms of the managed care network. So it has been going on for a number of years, and happy to share information on how to access that funding stream, if that would be helpful.
Yeah, could you give me an example of the sort of groups that can apply for this funding, the sort of voluntary groups that actually get it? Thank you.
Yeah, so just one example, walking groups, creative therapies, equine assisted therapy, where for autistic people, for example, working with animals can help, and it provides the social connection. So It's a really broad range, and it tries to be permissive in terms of the framework of funding. But I say I'm happy to share more detail on how to put applications in, if that would be helpful.
Yeah, I think that would be really helpful, because it's certainly, if we can get people involved in groups early on, I think it can transform people's lives. So thank you.
Absolutely.
Excellent, thank you. Justin, you want to come in?
Thank you, Chair. Yeah. The managed care network is really a jewel, really, in terms of our approach to prevention. We have got some materials we could share with the committee as well, in terms of examples of the schemes that have been funded over the years. We have had people present at former committees, and we could perhaps do that for a future one, if that would be helpful.
Yeah, I think that really would. And part of the problem is people never know where to go to for funding and how to start. So just a basic thing about who do you go to get, to apply for funding, I think would be really helpful.
Okay, yeah, we'll organise that.
Thank you.
I think it touches on a really, really important part as well, in terms of going back to this jigsaw analogy. And the really important part of the jigsaw puzzle is mental health promotion. So as well as, Sarah and myself working together from a health and social care point of view, Lucy, who's recently been appointed as the lead on suicide prevention and the learning disability and mental health agenda, but from a mental health promotion point of view, then all of that mental health promotion, the social inclusion part of it is a huge part as well. So it is how all of these different parts of the system work together, really, to manage demand in a more effective way. And prevention. The more that we can invest in maintaining and promoting good mental health, then the less pressures that will put on services further upstream. Thank you.
Brilliant, thank you for that, Justin. I've got Rob, Tracy, then Marianne. So, Rob.
Thanks, Mr. Chairman. Just following on from the comments that Councillor Lee made regards the helpline numbers, maybe it would be helpful if all members of the council could be supplied with these helpline numbers, so that if they're contacted by constituents, that they can put their hand to it and immediately give them the response they need. That's just an observation. Just a couple of questions. The SARC unit, I remember visiting it when it first opened. Have we got a massively increased demand on that unit? Sorry, that lapsed into jargon then. Sexual referral unit. I just want to know whether there's been a massive increase there. And also on the Longleys Road site, if I remember correctly, there have been some reconfiguration at Discovery House. And I also was wondering what was happening to Jervis House on that site. Thanks, Chairman.
Thank you. So in terms of the helpline, absolutely, I'll make sure that the details are circulated after the meeting. In terms of the SARC, the Sexual Assault Referral Clinic, yes, that is one area that has unfortunately seen quite a significant and prolonged increase in referrals. And the knock-on from that is that courts haven't been operational as well. So actually, in terms of the caseload for those workers, it's really backing up, because we're not sort of seeing the court cases coming to fruition and sort of that churn. And it's also linked to an increase in domestic abuse cases and impacts as well. But we are working with our commissioners to make sure that we've got some additional investment going into those services to increase the capacity to be able to deal with it. In terms of the Wolds, the Discovery House ward, you're absolutely right. We've turned it from a open rehabilitation ward into a reablement ward, and this is what's helped us to reduce our out of area patients, so patients who are having to go hundreds of miles for their care for acute mental health. Instead, what we're doing is we're increasing the capacity within county. So it's sort of a 28-day stay ward where we have that time to do the assessments and the reablement to make sure there's occupational health as Justin talked about, there's the housing offer available for people, so they're not in a mental health ward where they don't need to be. They're in the community, in their own homes, getting that community rehabilitation support. So that's been a really important part of our pathway sort of recalibration. And in terms of the Jervis House, yes, it's an old building and it's not fit for purpose anymore. Our staff deserve more in terms of providing services from that building. So we're currently vacating it and then deciding on the future of that building as part of the long lease site. Hope that answers your questions.
Okay, brilliant. Thank you. Tracy, welcome.
Thank you, Chairman. So I regularly receive comments from residents that are negative in regards to their experience of mental health services. The main things are actually getting the help, actually getting into the system seems to be their biggest problem. The other challenge that I hear a lot is that families don't feel updated, they feel out of the loop completely, and actually often the user also feels out of the loop. So those are two things that are very key for me within this. On one of the slides, you said at COVID times that you extended the community support, and it would be interesting to know which bits then will reduce from that community support that have been extended just during COVID. You've also said that you want to reduce hospital admissions, which I fully appreciate, and not everybody needs hospital admissions, of course they don't. But what worries me is we're going to be offering a lower level care to a lot more people, but there's still going to be the falling through the gap. So is the criteria going to be so high for someone to get that hospital admission? So that would be one of my other points within it. The support lines, obviously heavily used. But what next? What after that? How easy is that route? Once they've made that call to that support line, how easy is that route to then actually start getting some further help? Because many of those people, what was it, 650 a month for adults? Many of those are going to need some more of that. The other thing is the 18-week target. You've said if it's once crisis that it would be fast-tracked. What again is that criteria for really falling into the crisis category? Because again, there's many people who seem to fall under that at the moment, which concerns me, and they're being missed out. The nightlife cafe, is there any plans of action for South Holland for one of those to be there? And finally, in regards to the Shine funding, a lot of groups do amazing things. Councillor Key mentioned his community village hall and things like that. So many groups do amazing things, but sometimes they're very basic groups. So they're probably not constituted and things like that, but in their community do a lot. A lot of this funding that is released, I do find the criteria is too hard for some real true core but very basic groups to be able to actually access it. So again, I think possibly if that maybe could be looked at, but it was just a point I wanted to make, and that's it. Thank you.
Okay, thank you. Well, I'm disappointed to hear that you're hearing about it. Sounds like it's an accessibility issue and maybe people being kept updated. So if there are some specifics around that, then I'd be really interested to hear it. I mean, I do personally sign off all of the complaint responses that we have, but appreciate not everybody has the time or energy to raise complaints when they're not getting a good service. So really happy to hear specifics about that, because that's the key point, is we put services in, they need to be accessible. In terms of the South Holland Crisis Cafe, I'll get back to you on that one. It's being mapped out specifically in terms of the next steps, because we want to make sure there's coverage across the county. But we do need our voluntary sector to step up appropriately in those areas to be able to deliver them. So we sort of subcontract those. So again, that's something I can take back. In terms of the 18-week wait, we have crisis targets. So it's 4 hours for our crisis response. And we are meeting those targets consistently. And where we've got urgent or emergency requirements, as per the, it's always based on an assessment. We are meeting those targets as well. So it's more sort of the 18-week waiting where we're struggling to meet the targets. And then, of course, that's for your assessment. There's then a secondary wait in terms of your treatment as well. And that can sometimes be hidden, because if I'm honest, it's not something that NHS England measures us on. Therefore, it can be a bit of a hidden. So, it's not surprising sometimes, I guess, where people are like, well, I've got my assessment, now what? So we have just recruited a patient experience lead because we are aware that people will need some support. So are we offering them, for example, you know, are we saying this is the helpline number if you're waiting and you start to, you feel that your mental health is deteriorating, call this, rather than just the usual, which is you'll call 111 and then they'll tell you to go to A&E, which is not where they need to be. So appreciate the challenge, and it is a real one in terms of making sure that we're keeping people supported while they are on that waiting list journey. But if you've got specifics, I'm really happy to hear about them. We can pick those up. I don't know whether that answered all your questions. There's quite a lot in there, so.
I think just really about that criteria. But
Sure.
again, you've said you're hitting your targets for your crisis, but actually, really, where does that line come, and how many are close to it that aren't qualifying and they're not getting the help as quickly as they need?
Yeah, and I'm happy to share with the committee. We have an integrated performance report which sort of goes into that on a service line basis. So people would find that interesting. I'll make sure our latest one's circulated so people can see that in more detail.
Excellent.
Thank you.
Thank you, Marianne.
Thank you, Chairman. 3 questions, if I might. Firstly, I'm really pleased to see the thoughts and processes, and also that you are meeting targets and that we have no waiting list for, I guess that's for assessment, which is obviously clearly really important. First thing is, can I have a helicopter view? You gave us a view of your whole organisation, but how much is this transformation and what proportion of that is the whole? Are we talking about a significant injection of cash, which is making a huge difference in the service provided, or not? So I'd just be interested in a sort of helicopter view of the size of the impact you're expecting. Do you want to do that?
Okay, thank you. Yeah, so just for context, in terms of the mental health investment standard, which is sort of a mandated level of investment across the county. So it's something that nationally has been put in place to make sure that there's sort of parity of esteem between physical health and mental health services. In Lincolnshire, that's about 130 million. But that doesn't exclude learning disabilities and dementia, just for a bit of context. And the community transformation investment in the fullness of time at the end of the long-term plan should recurrently be in the region of £12 million. So not an insignificant amount of money. We're not there yet. Obviously, it sort of builds up as we roll out across the county. But it is, as I mentioned earlier, sort of the biggest investment for a generation. Because of all of the issues that we've talked about today, it's recognised nationally that they are issues across all of the country, and it needs investment to be able to bridge those gaps. But just on your point about the waiting list, we are hitting targets, but just to say there will always be a waiting list. There will never be enough money in the pot to eradicate waiting lists, and I think that's true across all secondary healthcare services. But what we need to do is make sure that we're doing the best that we can with our resources to make sure people are waiting as short a time as possible and supported in the meantime.
So just to clarify, I think what you were saying was 10% when it's built up to its full amount.
Roughly, yeah.
Roughly, thank you. Yeah, when it's built up after a number of years.
Yeah, 2024 is when it's supposed to be sort of the end of the long-term plan fully rolled out.
And I think that's revenue rather than capital.
It is, yeah.
That's great, thank you, that clarifies that. The help number, I think it might be the same as the Don't Bottle It Up one, which you gave us before, which I've just tweeted. Thank you.
I can find it now. That's correct.
I put it on the Lincolnshire County Council one. That's fine, and so that does come up okay. Actually, when you Google, it comes up straightforwardly, so that's all right. The second issue I wanted to just pick up is that I'm really, really pleased to see improvements in the service, and I must admit I had the same thoughts that the previous speaker had about making sure that we weren't disadvantaging the current service, the acute service, by putting this in place, but you clearly clarified that that's not happening and that this is very much an additional preventative approach, which is great. can I ask as a question, if a district council wanted to do a bit more because they felt there was a significant importance of the issue in their area, is there any particular way or any particular part of the subject where they would be best able to contribute? I think you may already have been in some discussions with members from North Kesteven District Council who are really keen to support your work. Thank you.
Thank you, absolutely. I think around the prevention agenda and the wider determinants of mental health, as Justin sort of so eloquently put earlier, around housing, employment, meaningful activity, physical health care, because there's no mental health without physical health care as well. So being physically active, and we're trying to do some work with Active Lincolnshire as well in terms of making sure that we're offering that and we're connecting in with those offers as well. But we do have district council representation at the Mental Health, Learning Disabilities and Autism Forum. So really excited about having a conversation there in terms of how we could take that forward. Thank you.
Brilliant, thank you. Well, I've got a couple of questions actually. One, when people ring up, there must be what I call themes, not themes, but issues that actually, in some sense, why they are calling. What is the trigger fact? What is it social isolation? Is it, what are factors behind them calling? Because there must be a sort of, I suppose, to target and identify and work better. What I haven't seen is what I would call, say, the top 10 sort of issues. What's causing people to go into, to reach out, to call that they've got a mental health? Something's triggered that.
Yeah, okay. I'm not a clinician, but we do theme in terms of reasons for calling. So we do get that as sort of a monthly breakdown, and it's back to your point about the social isolation. And I think because of COVID, it's exacerbated that. So it would be interesting to see what the activity would have been like without COVID and lockdown. In terms of people being furloughed as well, and social deprivation and the impacts on people's mental health by the uncertainty, lack of financial stability, substance misuse services, and how our services join up in terms of people who might have a dual diagnosis, in terms of a poor relationship with alcohol or other substances. But social isolation is a really key one. And that's particularly been the case as well for children and young people through COVID and lockdown.
Yeah, brilliant. That's good, thank you. And I mean, the one area that is an issue, diversity. I mean, the thing is, you can't just sort of set a cafe up and have everybody under the banner of mental health turn up to a cafe, because it's never going to quite work like that. The diversity between dementia through to somebody that's sort of had an accident, through to somebody that's got sort of food mental health issues, to somebody else. I mean, it does call, and that's why it becomes a really quite a complicated sort of arena. My next point really is cross-boundary, Scunthorpe. I mean, they've got a home up in Scunthorpe, I believe. And if people go there, because they do, say, from North of Lincolnshire County Council, is there a link back? Is there i.e., when they're in effect leave that hospital, are they then picked up by LPFT?
Yes, so we're actually part of the Humber Coast and Vale Integrated Care System at present, because we provide children and young people services into North East Lincolnshire, for example. So we are connected. We are trying to work more as a system, an integrated care system, but you can't sort of hermetically seal Lincolnshire, because there'll always be that cross-border traffic. So we do at all times try and make sure that we're working in around the person as opposed to around the geography, if that makes sense. But we have decided that we will be pulling out of our, well, we won't re-tender for children and young people services in North East Lincolnshire, mainly because of capacity issues in trying to operate within 2 integrated care systems. But as Chief Executive, I've said I'm very clear, this isn't a cliff edge where we just pull out. We need to make sure that we're doing the right thing by each of those service users in terms of those needs. And the same with the acute trust up in North East Lincolnshire as well. So NLAG we do work with to make sure that we're acting in a coordinated way around those service users.
Brilliant. Okay, well, that's been very good. And I think, right, I've just got Michael to come in.
Thank you very much, Chair. I've actually got a couple of questions. On reading the document, there was a reference to a new dementia home treatment team and as a pilot scheme. Do we know how effective that is at the moment?
Yeah, so in terms of our admissions, we've reduced them by 91% in older adult services. So what we want to make sure is, so the vision for the trust is to support people to live well in their communities. And I think we're getting the communities bit right in terms of we've avoided admissions. We just want to make sure it's quality services. So we are doing that evaluation piece now. Well, actually, we have already done sort of 6-month evaluation. And what we're finding is we do need a short-term sort of assessment area. So we had to close Manthorpe Ward when United Lincolnshire Hospitals at Grantham turned it into a green site to make sure that they could carry on with elective pathways and cancer care, for example. So we had to close our dementia home, our dementia ward at that point, which gave us the ability to pilot the dementia home treatment team model. So it has worked really well, but we're now looking at opening up Manthorpe as a shorter, smaller bed assessment and treatment unit, just to get people stabilised, get the right packages of care before they then go on into the community. So it's back to the an earlier point that we will never be able to eradicate beds completely, because people will become seriously ill. They'll need detention under the Mental Health Act, for example. But it should be as short a length of stay as possible to get people back out into the community. But, you know, from our review, it has been very positive.
Okay, thank you very much. And there was also, I noticed, Op Courage, where you're talking about veterans. How much interaction do you have with the various charities that service groups have set up to help with mental health problems?
It's a really important part of our pathway, and also in terms of the point was made about diversity as well, making sure that we've got all of the diverse needs of the veteran population addressed. But I could talk a bit more about that at a future session if that would be helpful, and there's been a number of questions on veterans, so I don't know whether it might be worth a more dedicated session in future where we could maybe get onto that a little bit more.
I would certainly, being an ex-vet myself, it would be a topic I would be glad to have on the system.
Great, happy to facilitate that.
Yeah, I noticed as well you've got the 24-hour helpline. Are these manned by people, or is it at a certain time of the day or night or weekends it's switched to a sort of an automated service?
It's 24/7 manned by trained individuals.
Thank you, I'm pleased to hear that. And again, we were on about, other councillors mentioned about promoting your availability of different groups. Do you think it would be possible to maybe use the county magazine once a year and you have a page or a large article that you could promote all your services?
I think that's an excellent idea, yeah.
Thank you very much.
Great idea.
Okay, right, well, I think I'll just try and sum up the best I can, and you can, I think there are various groups out there, and I mean, basically, in a sense, we know this service is valuable, we know it's essential, and it's complicated, and in a sense, somehow, you have to join it up. There is work to be done. There's no, you know, it's not, because it's such a hard service and it's been underfunded, there is quite a bit of work to do. There was talk about sort of the fact of how do we make more awareness of what goes on in communities. Well, we have a website which is a community hub website that was just launched by Public Health, which actually these sort of gatherings and events should be promoted through that website. What's it called? Anyone can remember? Is it called Community Hub Lincolnshire? Connect Support. Yeah. So hopefully all the information which would then help with the likes of Colin to know what's going on, that website should become the tool for that. So it's sort of, we start to drive. I think what would be good from this committee, if we could have a summary of the KPIs used in relation to LPFT, Section 75, mental health, so it's all in one. And with the telephone numbers, the websites in effect, i.e. your signposting, and the funding streams that are available. If we could just have a summary on that, I think it'd be very helpful for everybody, because there's a lot of interest in that, and it would just really sort of keep it bundled up in one pack of mental health Section 75. And if you're going to do that, it might just pay to do a bit of a briefing statement on the veteran, a summary of the veteran, and in effect we've got it all then concluded in one thing. So if I can leave that with Justin and yourself as a summary follow-up, might be, I think, the best way forward to keep everybody on board, and everyone sort of seems to be nodding and agreeing. So, but it's been very good. Very fascinating. You have got a tall order and you've got a challenge, but you know what, you're on with it, and it's something that I think both you and Wendy and Justin and everyone else that's involved relish for the fact that you've got this challenge and you want to make a difference in Lincolnshire, which is the absolute brilliant attitude to have. So Justin, did you want anything, or was that you're okay? So anything else, Sarah, or are you okay with all that?
That's great. Thank you very much for your time. Thank you.
Brilliant. Thank you very much. Bye.
Thank you. Bye.
Bye. Okay, we'll go on to item 6 then. Occupation Therapy, Disabled Facility Grants and Lincolnshire's Community Equipment Service. All being brought under one umbrella. So for this we've got Gareth Everton, Head of Integration and Transformation, Samantha Neal, Head of Prevention and Early Intervention, and Prashana Agwal, I haven't quite got that right, I don't think, but is also for Community Equipment and Telecare. Welcome all.
Thank you, Chairman. Hopefully you can see and hear me. Is that okay?
Yes.
Yeah, excellent. So what we've tried to do with this paper, I think committee had asked for an update on those 3 areas of service. What I've done with the paper is pull together some wider context around this in terms of the governance and assurance mechanisms that are in place. So within the summary, what I've tried to express here is that you'll recall from the Lincolnshire Health and Wellbeing Strategy that housing is one of the 7 priorities within that strategy. And as a result of that, we have something called the Housing, Health and Care Delivery Group, previously chaired by Councillor Bokit and now chaired by Councillor William Gray. And the work that is reported in here is a mixture of work that is owned by the County Council, but also by all of the partner organisations. We have within that group now developed a blueprint, which you have seen at this committee, and we now have a delivery plan taking that further forward. So that piece of work is now progressing quite quickly. There are services that we provide directly that, impact on people's housing. Occupational therapy and the equipment service are key ones of that in terms of enabling people to live independently and safely in their own homes. And as you'll be aware, disabled facilities grants are a statutory duty of district councils, but the funding for that comes through the Better Care Fund through to the county council and then is passported to the district councils to deliver that statutory duty. We're in a really interesting position at this point in time in terms of the equipment service. That has a significant pooled budget and a partnership board with representation from both the county council and the NHS, and we're currently recommissioning that service. We've had a very interesting year, 2 years, as you can imagine, in terms of delivering services which in some cases require going into people's homes and also meeting people face to face. So there's been a clear impact over the last 18 months on delivery of those services. But I'm happy to say that all three have negotiated that very successfully. And you'll see through the report that we have maintained those services and in many cases found slightly different and better ways of doing that. So the way that the report is structured is that it gives you information about adult occupational therapy in the first section, gives you some information around disabled facilities grants in the next section, and then the community equipment service in the third section of that. And as you say, my colleagues Gareth Everton and Prashant Agrawal are here to be able to answer any specific questions around those services. There's some further information then about the corporate priority in the corporate plan around a one-stop shop for aids and equipment, which I will just touch on in a little bit more detail now before we open for questions. If we were designing a service today that was aimed at helping people stay well and independent, perhaps when they come home from hospital, the way the services are structured at the moment are not how we would design it today. It means that a member of the public has to go to different agencies. In some cases, they're handed between occupational therapy and then back to a district council, but actually pieces of equipment come from a different service in terms of the equipment service. So generally what we have is a very complicated system for individuals to navigate. The aspiration and the ambition within the corporate strategy is to make that much, much simpler for people to navigate and to improve outcomes, improve timeliness of support and delivery, but also to have other conversations with people. And there have been occasions in the past where I think we have maybe put a stair lift into somebody's house, but we haven't really had that conversation about whether they can still manage in that house now and in the future. So there's a much wider conversation to have with people about how they can keep their home warm, whether they're able to be in that property for the long term, and what their aspirations are for the long term, particularly if they have a long-term condition that is going to impact on their well-being. So on page 36, what you have is some information about the principles that we're working to. The principles have been clearly tested through the Housing, Health and Care Delivery Group, which includes a wide range of partner organisations. It includes all of the district councils and the county council, both elected members and officers. And there is a very clear consensus that we need to do things differently. Having said that, moving into doing things differently involves some quite complicated areas of work. The relationships, obviously, with 7 district councils and a county council. There are different legal structures and processes. Finances need to be looked at. So there's a raft of things we need to take into account, but we are really clear that we are starting to make steps in the right direction. What we have lacked up until now has been some officer resource to turn some of the aspiration into action. And I'm really pleased to be able to report that we now have a project officer in public health who is tasked with taking this piece of work forward around the one-stop shop and working into the Good Homes agency work. There is a post to be employed by Boston Borough Council, which is being funded by all of the district councils to look at how DFG and related services link into the system better. And we've also got some really constructive conversations taking place now through the recommissioning of our equipment service around what sort of things could go into that contract, such as stair lifts, etc. So whilst these are fairly small steps, they are starting to give us the equipment we need to be able to accelerate. And the aim for 2022 now is, having got that consensus, having got the governance arrangements in place, having got staff in place to drive this further forward, is that we will be able to move towards now thinking very differently and implementing service change. And you'll see at the bottom of page 36 onto page 37, the next steps that we're looking to take in terms of tangible delivery. I would just like to highlight a couple of other things that have happened in recent time. And again, just to acknowledge the work that has gone into this. Our district council colleagues have been working with us for some time to develop a discretionary housing policy. This sits alongside disabled facilities grants. So disabled facility grants, mandatory grants, are covered by quite specific guidance. There are flexibilities for councils to be able to use in relation to their discretionary powers. And I'm really pleased to say that at the last Housing, Health and Care Delivery Group, all 7 district councils have signed up to a discretionary housing policy. And that means that they are able to act much more flexibly with the funding that they have allocated, particularly to do things, for example, like supporting hospital discharge, using their discretion to do things differently. And also we talked, I think, at the last scrutiny committee that I came to on this subject, and I think more recently about an equipment amnesty. And I know I had correspondence with some councillors after that. Prashant will be able to share more detail, but we have just signed off a proposal to look at a very specific amnesty in the early part of 2022. But our plans and proposals going forward now in the recommissioning of the equipment service incentivise the return of equipment. As you'll appreciate, once equipment is out in the community, it represents a significant cash value. Our thinking is very much about how we reuse that, how we maintain that, make sure that it's in a good standard, and having spent out on it, that we are able to reuse it multiple times where that's appropriate. So small steps. This is evolution, not revolution. There are a lot of relationships and a lot of statutory duties, etc., to unpick and navigate. But the point that we're at now is that we are very much able to accelerate into next year. So I'm going to pause at that point and just welcome my colleagues, Gareth and Prashant, both of whom are very much involved in how we take this work further forward. And very much now open to questions, Chairman.
Thank you. Andrew?
Yes, thank you. I was really interested to hear what you just said about the equipment amnesty, because this is something that I brought up previously. Could you tell us a bit more about that? I think you said one of the other speakers could perhaps do that. Thank you.
Yeah, Prashant, do you want to pick that one up?
Yes, of course. Thank you. Firstly, thank you for having me. Essentially, after you suggested that we did a bit of benchmarking exercise with neighbouring counties and found that this has been used in Hull and is used to quite a success, to be honest. So we spoke with the equipment provider, which is NRS. The idea is to have collection receptacles or bins in the 7 recycling centres where members of the public can deposit small pieces of equipment, which sometimes are not financially viable to pick up because, for example, a walking stick might be £2 and the collection charges and the fuel required and the staffing charge is far greater than that. So we were wanting to stimulate a lot of those collections. That is the basic premise of that. So we have been in touch with the head of waste management in LCC to see the feasibility of having a bin there, like Sam just indicated, that we have had the sign-off very recently, and we are working with the districts, with housing associations, and with all the partners, so that we put across communications out, so that we have a lot of traction, and members of public are aware of this.
That's great news, thank you. And it really is a question then of getting the news out and the publicity right, because I think that people do feel a bit, you know, they think there's a lot of wasted money in all this equipment. So it would be really good, it would look good, but it would also be really good to reuse these things. Thank you.
Yeah. And just to add to that, we do obviously have an arrangement whereby larger pieces of equipment are brought back by the provider. But I think what we really want to do, particularly conscious of two things really. First of all, the green, well, three things. The green agenda, which is significant in this. If we can cut down using new materials for equipment wherever possible, that's ideal. It also has a cost impact for us as a council, a positive cost impact. But also some of the equipment that we use is less easy to source currently for a number of reasons. So we have some real incentives for doing this. This is already within our contract, but this is over and above. This is about really pushing a drive forward on that to make sure that we maximise all of those.
Thank you, and thank you for doing it so quickly. Thank you.
Thank you.
Thank you. I've got, was Councillor Wendy, are you there?
I'm here, yeah. I just wanted to, can you hear me? I just wanted to say this has been a long time coming. Sam and I have been working on it before I think, come to county council. District councils, getting them all around the table, around the health, housing, care delivery group was a nightmare. And getting them all to sign up to it was even a bigger nightmare. But we have got there, we are there, and it's just excellent news. And this money is going to be spent better. Not saying that the districts aren't going to spend some money, they will still be able to spend some of it, but you know, to share it and buy things like the stair lifts, for instance, it's just going to be absolute saving money for all people around. And as for the reason using the equipment, Prashant knows that I'm really keen on this, very keen, not just for households, for nursing homes, for residential homes. You know, it's gone now, the days that we delivered a bed and we left it there. Prashant knows that I'm there watching him with my eyes and listening with my ears, and we will be, you know, getting everything back. If we can use it again, we will use it. So thanks very much, Tim. You've done a brilliant job.
Thank you.
Thank you. Tracy, would you like to come in?
Thank you, Chairman. I know the paper itself is a bit more about a bigger reshape and restructure. And so my points are possibly quite small details within it. But whether I need to declare an interest here, because I've been through all of these services with my mum. And I'll be honest, the equipment service, absolutely excellent, very, very quick, nice when they came round. It was the NR guys that you said about, very, very good, no issues there. The telecare service, again, very, very good indeed. One of my comments would be, I'm younger, you know, but it was a really tough time. It was a very hard time. Mum was in hospital for 4 months before she come out. One of the things would actually be, couldn't an appointment be for both of those things to actually be arriving and installing the same day? Because it's quite disruptive to have it too. And if I was an older person on my own, again, so that's kind of just a small thing. My other thing is more about the occupational therapy side of things. I found that side very, very disappointing, to be honest with you. So what happened is, and again, I'm a strong character, you can probably pick that up, but actually a lot of people aren't, and they're not going to be able to be as strong as I was. So when the occupational therapist came round to look at the house and talk about what services my mum needed, the focus was about one room. I didn't want my mum to be stuck in one room, and I kept trying to encourage the look around the rest of the house. Can we get her to outside and that kind of thing? And it was blocking me all the time. It was only about the one room. No one wants to come home from hospital and just be stuck in one room. I didn't find it inspiring. And actually the reality is, because of what we've done, actually my mum can get round all of the rooms, but that didn't come from the occupational therapist's inspiration in that. And it also, I felt railroaded, very railroaded indeed. So, for example, the room where we were setting up, bearing in mind I moved house, bought wardrobe, set up everything for mum in a matter of 3 days so she could come home. I hadn't got the heating done in that room. I needed a new radiator fitted. Again, the occupational therapists were not listening to me. They were saying, well, you know, we'll get her home. There's a radiator there. When I'm saying it's not working, I've got a new one being fitted. All my mum was a number and just about getting that bed back. And I genuinely don't think the family should be feeling that pressure, that it's just about getting that bed back out of the hospital and getting her home. So those for me are really important personal elements that I would love to see considered strongly within this. Thank you.
Gareth, do you want me to go first?
Feel free, Prashant.
Thank you, Councillor, for the equipment service and telecare. I accept there are 2 different visits because there are 2 different referral routes. But where possible, if there is one referral coming in, we do try to, obviously there is a green agenda which Sam touched on, so we do try to minimize visits. There is a service disruption, disruption to the person, not service disruption, and the green agenda. So we do try to do that, but I do take that on board, and where possible, we will try. But thank you for your kind words.
Just to expand on that, I think there's something about digital, about how adult care bring forward a wider digital strategy around the use of kind of technology, and appreciate what you said, that some people are more tech savvy than others and around how we design the right solution for people. Just around the feedback from occupational therapy, as an occupational therapist, I'm obviously disappointed in terms of the feedback and things we need to reflect on. It does sound like a potential occupational therapist from a different part of the system rather than an LCCOT. We have occupational therapists now employed across the range of health providers. And one of the pieces of work that I'm leading on is working with occupational therapists to have a more seamless pathway. So actually how we can work with our occupational therapy colleagues at the hospital through LCHS in primary care networks and focus on parts of that conversation. So every occupational therapist has environment as core of their assessment. So assessing the person, the occupation, what they want to achieve, and the place. Yet it's only LCC that have a statutory responsibility around statutory DFGs. And I think sometimes it's about taking the opportunities around the discretionary grants process to expand the scope of some of those practitioners and make it everyone's business to think about the person in their widest context and not just that room to get people out of the hospital. And I can understand some of the pressures and perhaps why that conversation wasn't quite the holistic view we'd like to see, but that's certainly work that I'm taking on board and trying to have a more person-centered approach across the system.
Thank you.
Okay. Well, I'll just come in and then I've got Marianne coming. I mean, for me, bringing all this into one is ideal. It makes sense. I think that the occupational therapists and the DFGs are the more complicated ones. The community equipment is actually quite relatively easy. It's generally brought, it's generally mobile, and it's generally returned. The other 2 get more complicated. And my only thing with the DFGs, which is sort of a bit of my sort of issue with them, is when we invest and then somebody moves or somebody does something and we don't get the money back. And I reflect back to the years when I was a district councillor and all the money invested at times, and I think that we lost out on a longitude of efficiencies of some of the equipment that went into those well, I say equipment, adaptions would be a better word. And it does sort of lend this point that there is a point or a trigger point at some point where actually spending £25,000 on somebody's house goes a long way to actually what we potentially need, which is extra facilities housing, or like an extra care, but actually not so much care, it's extra facilities. And in some sense, we should, there is a point where we should invest in extra facility housing and people have to move, because actually the costs that we do, it's about spending money wisely with a continuity. And I would like to see going forward something that acknowledges that, rather than this perception, and I don't know how bad it really is, but where we do spend, say, 25,000, somebody has the benefits for 6 months and then moves on. I would rather see 25,000 put in a pot and actually start to put strategically sort of flats with extra facilities or whatever, so it sort of met the needs of people. And it's like this whole sort of extra care housing is about multi-tiered approach, going up on a scale of care needs, and at some point we need something at the bottom which has flats or accommodation that people can access with wheelchairs, with wet rooms, with all the facilities that they need to live their lives better, rather than sort of throwing money into certain accommodations that we just never see it back. Thank you. Have you got any comments on that, or if you can bear that in mind?
Yeah, I'm happy to come back on that, and then I think that Gareth wants to as well. So I absolutely take that point, and I think one of the issues we have here is that we're working to legislation and working processes that are somewhat out of date. One of the reasons we were quite keen to enter a relationship with the Centre for Ageing Better is the opportunity that gives us to lobby back up into the system and use the relationships that the Centre for Ageing Better has to influence change around this. And this is certainly an area that they are very, very keen to progress with central government. The legislation does not necessarily work in our favour, but also it doesn't necessarily work in the favour of those individuals either. And I think I've certainly been in the position, as I know Councillor Bowkett has, as have others, of spending a lot of money on a property. The person then moves house and potentially wants that replicating elsewhere. So we have to work within the legislation we have at the moment, but I think the scope for lobbying to get that change is really important. I think there's also a bit of a balance here as well, and you referred to the extra care housing. That is really an area where we think that, again, we don't want to be putting a sticking plaster, putting a stair lift into somebody's house when they never see anybody all day, or where it's so cold that they're struggling. We've only done part of the job, so that wider conversation is absolutely important, and the organisations working together as one to address those. So that future view for people, and particularly as we have more extra care housing coming online, is really important. But I'm also really conscious that we do need, part of the reason for encouraging people to be independent in their own home is that often in that area they have a lot of social connections. They may have family support networks, they maybe have regular places they go to. So there's a bit of a balance here about where we perhaps feel it is better for somebody to move. Obviously they still have choice around that, but also there's a risk when people do move that they become more dependent on services and perhaps lose those social connections. So there's complexities around this that we're really aware of. But I think Gareth probably just wants to come in and pick up on that as well.
Thanks. Yeah, I'm just going to reflect that we haven't included colleagues from Children's as part of this conversation, because obviously it's a slightly different around a one-stop shop and the advice that was provided for people who are service users. I think probably Councillor Marfleet, the conversation there about expensive schemes being extensions, because a stair lift and a level access shower wouldn't usually come to more than £10,000. So we're thinking about the larger adaptation schemes, and actually there's relatively few that come within adult services. And because we can have that conversation about rehousing and moving, I think the majority of those and the cost pressures on the districts would come from children's services. And I think with the best one in the world, sometimes they are large families and there actually aren't properties out there. So the majority of times where we get involved, it's a 3 children, 4 children family that can't reside in 3-bedroom houses. There aren't any 4-bedroomed houses out there in the market, and that's where we're led to do the adaptation schemes. And then obviously children and moving around schools and the choice of where that education provision needs to be. People do tend to move. So I think we can absolutely work with kind of processes and policies to support the general rule and the 90% of people, but I think there will always be those real complex cases, and unfortunately people do sometimes have to move to where the provision is.
Okay, well that's sort of a bit reassuring. The one comment that sort of came out of that is sometimes we are bound by current legislation, and I think that I hear that quite a lot of times, and I think what we don't do is we don't often highlight it back. And as a nation, what we are pretty poor at is tinkering with legislation to improve it. We tend to sort of do it, put it through Parliament, and then never go back to it unless and I think sometimes we end up looking at all the different aspects. What we should do is raise it. We are part of like the County Council's network, we are part of the LGA, and I think that what we should actually, and it'd be nice from an adults committee here, to where we have certain legislation that really does cause us some issues, we should highlight it, and actually perhaps to this committee that we then highlight it as and actually promote it back to help sort of address some of the issues, because some of these issues are often rural as well. So that's what we're here to do. So if you do have some sort of legislation issues that are blockers, then please do let us know so that we can highlight it to the appropriate people to try and get fine-tuning, because that's what we don't do really well, and we should do better. And we don't highlight it, we tend to moan about it. On that note, I'll head over to Marianne.
Thank you very much. Just a few questions, if I might, please. Firstly, I think it says in the papers that we're spending currently about half the money that we could be. I think I understand on paragraph, page 32, halfway down, 4.3 million of the 9.2 was spent on mandatory. Then it does say elsewhere that the excess that there is currently being used to supplement the DFG, but also for repairs and improvements to the homes of people with disabilities, health and care needs. So I'm not quite clear on whether we're actually spending the money or not at the moment overall. I had actually cause to talk to somebody doing a task and finish group yesterday, as it happens, on this subject, and they showed me the benchmarked data from their colleague councils, and I think we might have even been in that group, though I didn't check the detail. But it seems that a lot of councils were only spending around half the money. So I don't know if that is the case here. I'd be interested in that. And allied to that is the point of this whole purpose, if I understand it correctly, is that we are already currently getting all of our equipment in a one-stop shop called the Lincolnshire Community Equipment Service, but you want to add in the occupational therapy and the DFGs in with that, if I understand that correctly. So it seems to, and then transfer it to another supplier. And yet the supplier here, where you've given a 2-year extension to March 2023, so nothing, if I understand it correctly, can be done before then, if I'm understanding this paper right, then, and their performance is very, very good, looking at the page 34 and 35. So I'm beginning to wonder exactly why it needs moving. Does it really need moving? If you want to add those things in, why not just add them in? I don't understand that. And secondly, if the money is not currently being spent, and in one place you do say it's gone into reserves, and then the other place you say it's spent, so I'm not sure which it is, but what is the case with the money? And the third point is, if it does move to a new organisation, what is the impact on staff on our district councils? Thank you.
Okay, I'll come in, because actually on 2 of your points there, this is just a paper explaining the concept. We haven't gone out to procurement yet. I suspect it's being shaped up, but we're not there yet. And actually, the current provider that's providing the equipment might end up winning the contract yet, so there's no done deal there, I don't think. So I think it's more about whether the money is being fully utilised.
Thank you. That does cover that point. Although you did mention the ageing one as if that was a done deal in your mind, if not on the paper, the Centre for Ageing Better. So I don't know what the situation is, but I'd be interested in the responses, if you wouldn't mind, just on what is happening with the money. What about the contract and the staff impact? Thanks.
So more than happy to cover those off. One of the reasons that district councils initially were very hesitant to be more flexible with what they use their budget for was that they have to deliver their mandatory grants. So what you're seeing in that table is that about half of the budget that they get is being spent on their mandatory grants. What that does is that now gives confidence to the district councils that they can have a discretionary policy and they can fund works through that discretionary policy without having spent that and then finding they can't fulfil their mandatory commitment. So yes, they are spending that 50% on mandatory. Yes, they are spending elements of that remaining money flexibly according to the policy that they've all just agreed as all 7. They do also have an element in reserve. So the government at the end of the year does not take back money that has been given for DFG, but because it comes through the better care route, we have asked the district councils to ensure that that money, if it is unspent at the end of the financial year, goes into a ring-fenced reserve. So if they have a significant demand in the following year, and it isn't as straightforward as a following year because work rolls forward. So what we are clear about is that that money that was given for that purpose is still there. And just to give an example, a district council like Boston gets a relatively small budget for doing disabled facilities grants. If in one financial year it gets 3 large-scale extensions to houses for 3 children, in effect that can wipe out the total amount of their mandatory budget. So for the rest of that year, until they get their next income, they wouldn't be able to do any discretionary work whatsoever. So all 3 of those things are right. They are spending on mandatory, they are spending on discretionary. Anything that is not spent within that current cycle is rolling. And as you'll understand, the timeframes for assessment perhaps and then absolutely building an extension is not going to be in the same financial year. So we tend to try to avoid calling it underspend because it's not. It's already committed to a case, but that case just isn't finished by the 31st of March, so there's no cut-off point in that way. So hopefully that will give you some reassurance around the budget. However, what it's also doing is because there is an element held in reserve, the districts are also then saying, well, actually, we have discretion with the agreements of the Health and Wellbeing Board over the use of that Better Care Fund money, and we are now saying we would like to use an element of that funding to employ an officer who can help us review what we do, how we do it, and how successful it is. And that is entirely permitted with that funding, provided the BCF, the Better Care Fund administration, supports that. And obviously in this case, we do. There's a relatively small cost in employing an officer to improve systems, processes, outcomes for individuals without detracting from the money it's being spent directly on those individuals in their homes. So hopefully that's clarified that element, and that is the position countrywide, as you say, Councillor, that the majority of organisations will be in that position. We've also had the experience in recent years of receiving very late funding, late in the financial year, usually around December time, and having a significant injection of short-term funding. Again, district councils have had to be very sensible with how that funding comes in, and again, that is able to go into a ring-fence reserve. So again, with quite a lot of disabled facilities grants, it's impossible to spend a significant chunk of money in 3 months because it just doesn't work that way for many people. In terms of the organisation and the arrangements here, the equipment service is a commissioned provider service, and it does what it says on the tin. It simply enables us to provide equipment. It sits quite detached from DFG services. So if you look at it from the point of view of the individual, very much as Councillor Carter has described, all of the bits of the system are there. They don't join up very well. They don't focus on the person, and that's why the sort of alliance that we're wanting to start to bring together starts with exactly that conversation. What are your needs? Do you need equipment? Do you need an adaptation? Is your house cold? It's starting to think about the house and the person in the round, rather than just saying, actually, well, we've got a service over here that can provide a piece of equipment. So I think the distinction is that's a very specific service. It's you're absolutely right. It runs really well. Prashant's done a great job as well of keeping on track of that, because it's been a very high demand service during COVID, with wanting obviously people to be back home out of hospital as quickly as possible. But what we're trying to do is to say, if we've got occupational therapists in the hospital, we've got them in the county council, we've got DFG teams, we've got an equipment provider, we've got voluntary sector organisations, we've got warm homes grants. Trying to navigate all of that as an individual is really difficult. Bringing it all together and trying to create that alliance or that network is absolutely where we want to be. The Centre for Ageing Better work is enabling us to draw on national expertise and support and some funding to test what that whole system approach might look like, and to use that as national learning. So we're not contracting or commissioning the Centre for Ageing Better. We're working in a partnership, utilising their expertise, enabling them to help us evaluate what we're doing and critically review what we're doing to make sure that we're not out of kilter. So hopefully I'm more than happy to have a conversation offline as well if that would help. I appreciate it's really complicated, but that's where we're at, I think, with housing at the moment. It's a really disparate set of services that somebody might need at any particular time. And we're dealing with people in really different circumstances, from families who have a child that needs support, through to working age adults, through to people who have an accident and within a very short notice are incapacitated, through to people who are either in their later years or have a long-term condition. So it is a very complex picture, and apologise if that hasn't come across clearly.
Okay.
Thank you very much. I think there's a lot in here that's good. Don't get me wrong. I recognise the extra flexibility that is itemised here, and the joint thinking across the districts is clearly beneficial, and the proposal to make sure that things are well coordinated. My point really was just to make sure that we don't lose anything in that process, and so thank you.
Okay, brilliant. Thank you. Right, I've got Mike and then Tracy, and then I'm proposing that we take a 5-minute pit stop. Otherwise, I think some of us will be frozen. Thank you.
Thank you very much, Chair. Glad to see that we're going forward and thinking of more joined-up cooperation. I just wondered, when we go to sort of your next step phase, I don't know whether it's possible, but could districts, through 106 agreements, obtain funding whereby you could have small clusters of assisted housing and therefore be able to provide a service that runs more smoothly to those people that need assistance? Thank you.
Thank you. That's a good question. I think probably generally not through Section 106, but what I do know is that individual district councils do take that into account. So I can think of examples in East Lindsey, for example, where somebody came forward who needed to apply for a disabled facility grant. They knew the area that the person was connected with. There was a new housing development taking place, and they were able to intervene at the point of that being built to make sure that it was then equipped for that individual. And that worked extremely well in that case. It's always better if you can build those things in rather than try and retrofit them afterwards. There was a risk that the district council took with that, that the person wasn't in a position there and then to sign up to that property. So there was a risk that the person might have stepped away from that and the repairs or the amendments were done. But actually that worked extremely well. And we do work with district council colleagues on that basis to look exactly for those opportunities, and particularly I think for working age adults who are maybe likely to have both employment and family connections in those areas. So that becomes a really key area. And I think just to reassure you, that's exactly how we're working with district councils in the work around extra care, which I know Gareth is very involved in, that we're constantly looking for sites. Did you want to come in on that, Gareth?
Exactly what I was just going to say, Sam. With some of the districts around Section 106 money that's been part of the extra care capital contribution to get the schemes delivered. So I was just thinking probably more about further iterations of extra care and how that might support alternatives. But yeah, it needs to be a district council by district council conversation, I think.
Okay.
Thank you. I've got one more question for you. Do we know if the districts keep a register of all the various properties that have done work and the type of work that's happened there, so it can be monitored and made better use of as we go forward?
Again, that's a really good question. So I think broadly, yes. But bearing in mind that different types of homes will be adapted. So clearly some of the work will be taking place in private homes, a lot of the work will take place in private rented, and a lot will take place in housing association properties. Wherever possible, I think district councils have a lot of influence over the housing associations. So it's much more likely that as those properties become available, that they will alert the district council and say, you know, we've got a fully adapted bungalow. Is there anybody on your list that this is suitable for? So I absolutely know that those conversations take place. Equally, we have had frustrations, and I think the districts very much have, where you know, perhaps a private rented accommodation, perhaps the individual owner of the property won't allow repair amendments to be made to that because they see it as not being feasible for the future. So the relationships very much determine what is possible with those. We don't have a specific register as such, but again, I think it's something that the councils are very alert to, and it's certainly something I think we want to look at further forward, that there are options around how we could do that better. But yeah, to a degree, formally, those relationships, those conversations do happen in local areas.
Thank you very much.
Thank you. Tracy, have you got a quick one to come back with?
Yeah, it was just a quick one. It's very similar to what Councillor Clark has just asked about. What engagement do we actually do with builders as well as the district? So getting in early at the planning stage, but actually, do the builders understand that the demand that is there for those properties, maybe one on each site that they could choose to do? Of course, there's extra cost in low-level showers and things, and everyone again is an individual, but there are common themes in adapted houses that are needed, such as the low-level showers. And I don't mean the extra care sites. I mean the traditional, you know, residential sites. I don't agree with clusters or anything like that. You know, why would you treat people to want to put them into a cluster? So my view would be really early engagement, be it whether it's an offset, that one house in the housing association or affordable housing on each site, one of those has those standard adaptations made, and if it costs the builder a bit more, we offset it against a reduction on education or one of the other areas. Those are those early conversations, and direct with the builders, that I think would be important.
Yeah, and again, through you, Chairman, one of the areas that we have seen as a development in the last year is through the Housing, Health and Care Delivery Group. The elected members who are around the table there often have a shared portfolio between housing and planning, which is really helpful. And where they don't, we know that they are having those conversations back at base. And I think that this is one of the things that we want to take further forward, again, with advice from the Centre for Ageing Better and the work they've done nationally about what a good home standard looks like, whether it's a new build or an existing build, and really encouraging districts to build that into their planning policies. There's a lot of pressures, and I think this is one of the things we struggle with across the system is there are a lot of pressures in terms of, you know, are we wanting houses to be green standard? Actually, yes, we do, but we also want them to be accessible. So that we're sort of layering, if you like. And I think, you know, we have to be realistic. And I think I heard the comment earlier about sugar and manufacturing sits in the hands of business community. And actually, to some extent, it does with builders. Having said that, I think the local relationships with local builders is really key to that. You know, we have probably less influence over the really big developers that come into the county and much more influence with those smaller developers who are perhaps building out very small areas and that. What I would say is that we operate for disabled facilities grants now. Another of the innovations over the last couple of years is we now have a through our colleagues in the commercial team, a register of builders who can do DFG works. They've negotiated some pricing around that so that there's some more equality across the county, but also some standards around that, not least safeguarding standards with builders going into people's homes, but also standards around what we're looking at in terms of what that work needs to be. So there's a call-off arrangement there from that register of providers. Some of those providers are only likely to be doing adaptations and sort of minor works, but some of them will also be bigger companies as well. So we've used that opportunity and maybe again probably into the next year once things have quietened down a little bit with COVID, because it's not an essential piece of work to do now, but over the next year to 18 months I would hope we will refresh that that list of providers again, because there will have been a lot of change in the housing and the renovations market. But I think that's really key, is making sure that we use those smaller businesses and make sure that smaller businesses are getting the commission as much as the national providers as well. Thank you.
Okay, brilliant. Right, well, that's all very good. I think just on perhaps a point on that is that in some sense taking this all forward with the adaptions, etc., we should perhaps just have some form of mechanism that we can actually make sure that it is good value for money that is being spent, and there should be a check, because it is one of those things, if it does run out of control, then, well, if it went very high and wasn't very effective, there are better ways that we can look at it, and therefore we should have a measurement going forward to ensure that actually we are providing an efficient adaptation service, because we can always look at other options. Okay? Right, we'll take a quick 5-minute break and then we will return back. So thank you very much for that, everybody. Right, welcome back everyone. Just like to say Councillor Liz Sneath has given her apologies because she's had to go and see her mother, so wish her all the best, and I'd like to welcome, go on to item 7 and welcome Heather Roach, Chair of Lincolnshire Safeguarding Adults, and Justin as well. On this one, welcome Heather, and apologies for the slight delay, and hope you're warm enough to be all right. I'll let you take it over.
Thank you, Chair. I was going to say good morning, it's good afternoon now, isn't it? Thank you for inviting us back to speak to you today, really to present further on the role of Lincolnshire Safeguarding Adults Board and the work that we do. So we're going to do a bit of a two-parter. I'll start off and then I'll hand over to Justin. Just recognising that obviously some members are new around the table, and for others it will be more of a recap around what we do and what our role is. So if we just go on to the next slide. The Safeguarding Adults Board is a statutory board. It was created in legislation under the Care Act of 2014. And essentially we have to have 3 core partners around the table, which is the local authority, the local police and our local health community, which at the moment is obviously the CCG. We are made up also of probably about another 20 partners as well, and that is outlined within your document. But basically we have district councils, we have DWP, we have SAFA, we have the university, and we have voluntary agencies as well. So we have a real wide range of partners who sit around the table with us. We have, it looks quite simple, 3 core functions really, which is about publishing a strategic plan for each financial year about how we'll manage safeguarding. We then have to publish an annual report reporting on that progress against our objectives, and we also have to commission and conduct safeguarding adults reviews, which is in accordance with section 44 of the Act. To put that in real simple terms, we have a role around the assurance, making sure that safeguarding arrangements across the county are effective. We provide that sort of strategic leadership oversight. We also have a big role in prevention, and we also have a big role in learning and changing service practice and practice delivery. So essentially it's about ensuring that our arrangements are correct. So moving on, just to recap around what is safeguarding, because it is different to children's safeguarding. Essentially it's about protecting an adult's life, adults' right to live in safety, free from abuse and neglect. And that's really about people living their best lives, having a meaningful life, contributing to society. It's everything that we are. It's our friends, our families, our hobbies. It's what makes us us. It's also about the organisations across Lincolnshire working together to prevent abuse and neglect. I'll come on to abuse and neglect in a second. And also the promotion of wellbeing. And as a local authority, you have a duty under the Act as well around the promotion of wellbeing. Essentially, so does everybody really, because it all adds to trying to prevent people from suffering from harm and abuse. The difference between adults and children's safeguarding really is very much around you have to have regard to that person's wishes and feelings. So that person is at the centre of everything you do. And there is an ethos really which runs through safeguarding, which is making safeguarding personal. It's working with people, in general, taking account of their wishes and any action that they want taking on their behalf. That is, of course, if they have the mental capacity to be able to make that choice. Sometimes they do make unwise decisions. Next slide, please. Sorry, you're on it. Again, just going along that theme, often adults have really complex interpersonal relationships. Safeguarding can be quite difficult, but if you look at the sort of time when a statutory involvement, a formal involvement is required, we're not talking about everybody. We are talking about people who have care and support needs. And care and support needs means that individuals who've got, say, disabilities, mental health issues, physical issues, frailties, addictions, you know, the list is quite endless really. You then have to say, well, are they at risk of experiencing abuse and neglect? And again, if you look at what abuse and neglect is, there's a big range of that. Again, from physical abuse, financial abuse, domestic abuse, psychological, there's about 10 different categories. And the real key issue around adult safeguarding is that because of their care and support needs, because of their disabilities, complexities, etc., they're not able to protect themselves from that harm or abuse. And that's when there is the statutory involvement required. So just a little bit about the board. We very much work with our other partners in Safeguarding Children, the Safer Lincolnshire Partnership, and what we've done I think is quite unique within the safeguarding world. We formed, if you like, a collaboration across those boards, including domestic abuse. We've agreed a memorandum of understanding, and basically it's about having a shared approach across the boards and looking at cross-cutting themes that affect all of us. We've looked to share resources, a little bit around multi-agency training, audit and a communications plan. And for the first time ever, we've developed a shared strategic needs assessment to look at the county of Lincolnshire. And we're in the process at the moment of meeting together to look at what our priorities should be going forward. One of the key issues that came out of that needs assessment was looking at a prevention strategy which goes across all of those boards. Next slide, please. I talked a little bit about our assurance role as a board, and really this is a very quick snapshot of what we do. As I said earlier, you know, it's leading and ensuring that the arrangements across the county are effective. We have what we call the LAF. It's an assurance framework which is very similar to what Children's do. They send a Section 11 out to partners for them to complete on a regular basis. And we do a very similar thing which allows partners to then gauge themselves against the criteria that we ask them to look at, and then we will look at that as well. We've also, to strengthen that, had some assurance events this year. Both our executive and partnership groups have taken part in that, and it's been very focused around the COVID-19 pandemic and the effect upon safeguarding. So how they manage through that time period, where are their gaps, what do they need to do going forward, and what do we need to do as a multi-agency body to move forward. Some of the key themes that came out of that are really an increase in referrals post the first lockdown, more complexity around the referrals around safeguarding, and the severity of health issues as well. Staff burnout, lack of resources, difficulty in recruiting, issues around self-neglect, in terms of sometimes people not accessing healthcare, you know, as quick as they would have done pre-lockdown. Some of the positives that came out of it also though were more around collaborating together, working together better, and more willingness to innovate and come up with new ideas. For example, you know, one of the things that's worked better is the virtual meetings, where you do get more attendance from people who potentially wouldn't have been able to do that before. So there are some positives out of it. One of the key aspects that is part of our role is about learning and changing practice. There was a national review around the safeguarding adults report done in the last 12 to 18 months. And what we've done is look at that report against how we conduct our reviews. Out of that, we saw that there were some real key themes that come out across the reviews all the time, which are professional curiosity, the sharing of information, and how to deal with complex cases. And so what we put together for October was our first practitioners learning event, excuse me, online, really aimed at the front line and looking at those three key areas and giving some advice and assistance around how they should tackle those particular areas. We also support the Safeguarding Ambassadors programme, which is people within residential care homes not being safeguarding leads, but having that little bit more awareness. We come together with Lincolnshire and the CCG, and I went and presented at their last conference in November, particularly around accountability. We've just recently put together some guidance, further guidance around the Making Safeguarding Personal concept, and we're about to run a campaign in December with the Children's Partnership, which is about online safety. And what that's going to look like is some of our local stores, our local Asda's, Tesco's, Vodafone, every time somebody goes and buys a piece of equipment, a phone, a tablet, etc., they'll be handed a business card which has got the children's and adults information on, and it points them in the direction of where they can get further guidance on our websites around keeping safe online, so working together to raise that awareness. So I'm going to stop there and just hand over to Justin to talk about one of the biggest programmes we've really got under the board, which is the Team Around the Adult, and he'll give you that update.
Thanks, Heather. So I did actually touch upon Team Around the Adult last time I visited the committee as part of an overview of my service areas. And as I say, Team Around the Adult is really a centre stone really of our existing prevention strategy for the board. And as mentioned last time, it looks at supporting people who don't meet the thresholds for Section 42 inquiries, Section 42 of the Care Act, and also for people who, for whatever reason, choose that they don't want to engage with particular services. And again, this did emerge out of one of the serious adult reviews. So as Heather says, the board and the strategic review process really does inform learning and recommendations for improving safeguarding practice going forward. And really the prevention strategy works all evolve from that. So really important. And the Team Around the Adult did build upon the existing vulnerable adult panels or similar within the district councils. Again, being a little bit future focused, if we could. Yeah. So our ambitions really is around that theme of integration. There isn't really much point in having 4 different prevention strategies, each under each of the boards. There are some common themes here, so it makes much more common sense if we get all of the strategic safeguarding boards, statutory boards, actually signing up to one prevention strategy in Lincolnshire. And what we do want to do is also build upon Team Around the Adult in terms of that being still a fundamental part of that joint prevention strategy. Now, as well as having a referral process, if you like, into Team Around the Adult, our ambitions for the next step for it is to develop it into a more targeted service, and in particular focusing at people with more complex needs. So myself, working with LPFT, are currently doing analysis of referrals to our emergency duty team for people who've needed a mental health act assessment, and also people who've been referred to our mental health crisis teams, and actually doing some mapping work across those 2 referral routes in terms of actually seeing frequent flyers, if you like. So some of the early signs of that mapping work is there were 37 referrals for one person to the EDT for a mental health act assessment, and only one of those referrals actually the outcome was a mental an admission to a mental health inpatient provision, and that was a voluntary admission. And so therefore we want to unpick actually what was the outcomes of the other referrals, and actually is by looking at the top 10 people who are being referred, are they also the top 10 who are being referred to the mental health crisis team? Is the bounce in between? But most importantly, can we actually reconfigure services to deliver better outcomes for these people who are just bouncing between the system, really, so that they can get support quicker, and that we can reduce demand on services, but most importantly get better outcomes for people. And it comes back to the theme that we had this morning around mental health services. we will never be able to meet demand if all we do is carry on working like we are doing. We fundamentally have to transform, and we need to be able to work in smarter ways and being able to, you know, use early intervention and prevention to actually stem the demand on those really high cost and sort of more clinical services, really. So again, really, really, you know, excited about this initiative, need to build on it, and you know, it's going to deliver good results. I think the next slide is questions, Chair.
Excellent. Well, it's I think your team around the adults is very key. I mean, the more we can sort of intervene on an early prevention, the better with it all, isn't it? Without a shadow of a doubt. It's just sometimes identifying the people that actually often need the sort of support at that early stage is the harder part. But right, I've got Mike and then Karen and then Nikki.
Thank you, Chair. A safeguarding issue. I noticed in the report it mentions where some people go through a process of treatment, drop out, but then, as it were, go back on the path of addiction. I wonder whether, when you mentioned in the other part of the report about continually being represented to agencies, whether we come up with a different means of handling that particular individual, or is it always through the same process in the hope that you become successful the second or the third time in order to get them off their addiction?
So thank you, Councillor. Yeah, the whole aim really of the team around the adult initiative in terms of this next stage is to actually to do that research and to look at people's journeys through services and what handoffs they perhaps are. And absolutely, you make the point, we can't keep doing the same. We have to look at actually how do we provide those interventions in a different way. So, you know, I mean, in terms of our definition of those people with complex needs, we are using that as people who may have drug and alcohol addictions, mental health needs, and at risk of homelessness if they're not already homeless, really. But really focusing in on those people who do regularly present. So, yeah, it's exactly that. That's what we need to do, to look at doing things in a different way. Does that answer your question?
Yes, thank you very much.
Thank you.
Valid point. Karen?
Thanks, Chair. I just wanted to thank you again for a really comprehensive report, Justin. I think it's clear. I think it's a really sad thing, you know, the statement that you make about never being able to meet the need, because that's a bit of a sad reflection on society as a whole, isn't it? But I think it's good that you're doing so much work. I like the stuff around the team around the adult and, you know, the difficult to reach people, and that the people regularly present, because we've all seen those people in A&E, they're there all the time, aren't they? You know, and it's just good to see that there's some really good work being done, and thank you for bringing just such a comprehensive report. Thanks.
Thank you very much.
Nikki?
Thank you, Chair. Yeah, I'm interested in the team around the adult. On page 42 of the report, it talks about the team around the adult initiative, building on the vulnerable adult panels operated by the district councils. And I was just wondering how often, because it doesn't say how that's measured, how often are the VAPs asking for support from the TAA? And also a bit further down, it says that the initiative is a key part of the Safeguarding Adult Board strategy, and it's been significantly successful. So, you know, that could mean 2 cases, 10 cases. How significant is it? Can you give me a bit more information about that, please?
Yeah, so it is an initiative, it's a pilot, so we are, in terms of the volume of cases, we're not talking hundreds, we are talking sort of in the tens of referrals. But I mean, I don't know if you had opportunity to see Steve's story. It was one of the video clips we released after the last discussion to the committee. But that was sort of gave the next steps for it is, again, being really, really targeted with this initiative. And in terms of probably a relatively small number of people that are using a very significant amount of capacity within our system. So if we can free that up, that'll make sure that there's more capacity to help a wider range of people with maybe lower level needs. Does that help?
Yes, it does, yeah. I just wanted to touch base with you as well about complex needs, because we've talked this morning about there's so much work to be done, isn't there, really, right across the piece around health, mental health, housing. It's all linked to everything. Am I on? I'm on. Yeah, there's so much that's linked there to do with housing and mental health, and there's a huge amount of work to do. But really, it was just around what are complex needs, because there's so many of them, isn't there? How do people satisfy that criteria?
So you're absolutely right, and that's why we working with the district councils in a wider partnership, as part of the initiative, we came up with some criteria in terms of what we would consider complex, but also some scoring, if you like, in terms of level of needs as well. So I'd be happy to share that matrix with you, if you like, just to see how, from a team around the adult perspective, we measure it. But the term complexity is used in different contexts, isn't it? It is used differently in mental health services, learning disability, in terms of our commissioning activities than it is there. So it varies on different parts of the system. But I can share how we use it with Team Around the Adults, if that helps.
Thank you. Yes, that would help.
Okay.
Thank you.
Okay, thank you. Andrew?
Yes, thank you. I think this relates as well to the next item on the agenda, which is the performance report for referrals to the authority that proceed to an inquiry. I remember when Safeguarding Adults sort of came about, really. I worked for the registration service, and we had a lot of training on what to do for spotting people that may be at risk. And I wondered if part of the board, whether you look at the ongoing training for all the organisations, because obviously things are coming into the authority that aren't being progressed to an inquiry, but maybe they need to go in another direction, and people don't always know what to do. So, thank you.
Yeah, thank you. So absolutely, training is available on an ongoing basis through LSAB and through offices within internally in terms of LCC. But you touch on a really, really good point, and that is about its continuous need to retrain, and I think target some of that training as well.
Yeah, I just get the impression that obviously it was a really big thing initially, because I was sort of trained at the time, and I don't know what's happened since. But sometimes these things can not slip, but everybody assumes everybody knows, and perhaps a lot of people don't really know. And it may just tighten up the system and mean that we don't get so many inquiries coming in here that perhaps should have gone elsewhere.
So it probably will come back up in the performance, I agree, around the safeguarding concerns that are raised, that no further action is needed because it doesn't reach Section 42 inquiries, and that is increasing as a proportion of it. And what we've done is that analysis of actually who is sending us the most concerns that don't convert, don't meet those criteria. And predominantly it is the police and EMAS at this point, although from the care sector there is some work to be done as well. So there has actually been a goal group set up, which Di Coulson is leading, because there's a similar effect on referrals being made to the domestic abuse service, where equally they're not actually meeting their criteria as well. So what's going to be one of the key themes that comes out of that is a need for training for frontline staff.
I do wonder sometimes as well what happens to those people, because they maybe still are at risk, and do they slip through the net? I always worry about people that don't meet criteria for this, that or the other.
So Team Around the Adult is there as that, because it's in the prevention territory. So Section 42 is the statutory reviews, But as a board, we've looked at those in terms of we regularly quality assure the cases that don't make it through to Section 42. One, for quality reasons in terms of has the decision making been correct by the professionals who are looking at them through triage, but also then looking at, are there any trends or themes in there as well in terms of what we need to feed into our prevention strategy and look at as well. And certainly that was a bit of the thinking where Team Around the Adult came from, wasn't it? That a number of the concerns were very, very low level. So, for example, it might be, I don't know, a resident's bumped into another resident in a care home and a cup of tea's been knocked over. Well, in terms of that doesn't really need any follow-up. But actually, there may be things that are on the borderline of being needing an inquiry that actually it would be worthwhile having a Team Around the Adult strategy meeting and seeing if we could engage with that adult and doing something to help with them.
Yeah, that's great. Thank you.
Yeah.
Thank you.
Okay. I think it's a very good bolt-on into the service, actually, the Team Around Adults. Just a final one from me is social isolation. What is the impact into it? How big is that, do you think, as a single factor to neglect or some of the issues?
I think it's difficult to really say. I mean, we have been in unprecedented times, and particularly it's not necessarily older generation, is it? It's people also with learning disabilities, etc., who have found themselves in a position that they're not used to, and I think the impact will go on for some time. So I'm probably not going to be able to say, I really don't know how big that impact is, but I think services are feeling it, and it's trying to get services back into where they were pre-COVID, basically.
Yeah.
So
it's worth just sort of paying a bit of attention maybe too, just
absolutely.
To see if
So
that is a factor.
there's clear evidence that social isolation your health will deteriorate over, and so if there's anything we can do around the prevention agenda, it links back to our prevention arm of adult care and wellbeing and the work that Derek and Lucy are doing as well, and SEM, doesn't it? So I think it's and that community cohesion as well around helping your neighbour and breaking that social isolation as well. So I think there's a lot to go at there, and it would be very helpful from a prevention perspective, not just from safeguarding, but demand on mental health services, demand on adult social care, and just promoting overall health and well-being. So I think it's a very valuable area to look at.
Excellent. Well, thank you very much. I think that's been a very useful update, and keep up the good work, and I think it's sort of coming together nicely. So, brilliant. Thank you. Have a good trip back. And right, we'll head on to number 8, item 8, performance report. Caroline Jackson.
Thank you, Chairman. Just checking everybody can hear me okay.
I think, you can take it.
Excellent.
We've all read it, and perhaps just if you want to just highlight some of the key bits.
Yeah, absolutely. Conscious of the time. So hopefully page 45 of your pack outlines the performance report for Q2. The appendices, page 49 to 87. I will acknowledge there's a couple of formatting issues in the appendices. We've had some technical issues this quarter. We'll make sure they are addressed. And if anybody would like an updated version with those issues addressed with just some of the formatting, I can get that out to you. So in terms of Q2 reporting then, we've got 18 measures that we can report on this time. Really positive picture with 13 of those measures that are either exceeding or achieving their target, with 4 that aren't. I'll just briefly touch on those that are exceeding the target. A positive picture around the percentage of people aged 40 to 74 being offered and received an NHS health check. Although this has dropped ever so slightly in Q2, it is still achieving its target, which is a real success given the impact of COVID, although we're yet to see the full impact of this of COVID on this measure's performance because there is a lag in reporting. But what we can say is, although NHS checks were paused during the pandemic, over half of GPs are now delivering some health checks to patients, although we are expecting a little bit more disruption to fall through on the data in relation to shortage of blood bottles for testing. But all in all, at the moment, still showing a positive picture. In terms of permanent admissions to residential and nursing home for those aged 65, again, this is continuing to show that we are exceeding our performance. And as previously mentioned at committee, this is in part due to the continued work of teams to make sure that clients, where they want to, remain in their own homes for longer, if that's the best option. But no doubt there's also been an impact of COVID on this measure. And the third measure, exceeding targets, is was reported last quarter, which is the request for support for new clients, where the outcome was no support or a lower level of support. Again, continued work by the teams to ensure that non-service solutions are available to our residents, and that we ensure that those solutions are available. And also we do acknowledge that within this data there are a number of ongoing assessments where we haven't actually got an outcome yet, and also financial assessments. But all in all, a continued positive picture. The 10 measures that are on target are all in the pack. I won't go through those given the time. In terms of the 4 measures that didn't achieve their target, so one is down to a change in kind of practice in the way we've approached our assessment of carers, and it's around the carers supported in the last 12 months. So we've made some changes to the completion of the adult care client assessment form, which is in order for that, when that assessment is completed, in order to be a joint assessment, which is what is used for this measure, both the client and the carer's needs need to be considered at the same time, and questions are directly asked of the carer within that assessment process. So it's a change in practice which has shown fewer joint assessments being counted in this measure, but actually it actually does show therefore a better and more comprehensive kind of view in terms of ensuring that those questions have been appropriately asked. And we are also now including young carers in this measure by joining up our reporting with children's services. In terms of people supported to successfully quit smoking, again, we know that this has been a challenge during the pandemic, and that One U Lincolnshire have adapted to deliver their services online, which has been mentioned at previous committee. They've had minimal support, obviously, from subcontractors such as pharmacies, GPs and practice nurses, who's obviously been diverted onto COVID-related activity. But during quarter 1, this is a lagging reporting, but during quarter 1, GPs and pharmacies did achieve 164 quits and 62 4-week quits, which is a success rate of 38%. So we're starting to see that come back on stream. In terms of carers who've had a review of their needs, again, a small drop in terms of the performance here of the carers that were assessed. That have a direct payment, 75% have had a review of their needs in the same period, and of those reviews, the 93.5% are undertaken by our carers service, with just 6.5% undertaken by the adult care teams. We are looking at changes in practice to ensure that we can improve the performance around this measure. And finally, one that we've already touched on in this morning's meeting, which we've in previous meetings, is around the adult safeguarding concerns. Again, we are not achieving our target, as previously discussed, and as Justin has mentioned, we're working with our partner agencies to ensure that we there's appropriate training for their frontline teams so that they understand the criteria for adult safeguarding concerns. Given that a significant proportion are not progressing to an inquiry. So we're ensuring that there's a review of that referral process with our stakeholders to make sure that their understanding is clear. And then just finally to say, we will be working and are working towards ensuring that we have a measure around adults aged 16 to 64 living independently. We're working with our partners at LPFT, and we will hope to have that reported for you in Q3. I'll hand over for any questions.
Excellent, thank you very much. I've got one first and then Mike. The percentage of people aged 40 to 74 offered and received an NHS health check. Is there a mechanism in which we can I mean, if we're looking at the whole sort of sugar and weight management, then that's obviously an intervention point, or a point where we can actually find further information on weight and the percentage of people overweight. Because I think they get weighed? Yeah. I presume they get weighed. So, is there a mechanism that we can get down to that sort of weight management issue out of that, or is it an NHS thing that we can't get the information back, or is there, because actually potentially that's a pinch point that we with the sort of sugar thing can actually get an interjection at.
Thank you, Chair. Yes, it is largely an NHS delivery. Once a health check has been undertaken, people will be referred on to other routes, depending upon what that health check has revealed. Sometimes it's as a consequence of poor diet or a weight issue. There might be other issues as well as part of that, but they tend to get referred on by the GP or the nurse who's making that health check.
Do we get, I suppose, is that good? Is it a good service that they referred on to? Because
Thank you, Chair. So we do know that health checks are terribly important in particular groups in the community. People who do not have health checks tend to have poorer outcomes. There is some national data which indicates the relevance of a health check, particularly to some groups in the community, like people with a learning disability.
Yeah. Brilliant. Thank you. Mike?
Yeah, one of the stats on page 49 refers to permanent admissions to residential or nursing care homes for those aged 65 or over. It sort of gives a flavour that there's a reduction of occupancy. Do we then promote respite to possibly give carers a break from the task of looking after the elderly?
Thank you, Chair. This data refers to largely the year in which COVID had its major impact. That's rather hoping that it doesn't in 21-22. The data I would not take as necessarily setting a precedent or a trend. I think it's a particularly unusual year, and a year in which nationally the use of residential provision dropped significantly. There has been, in Lincolnshire, a growth in demand for home care services, and that is one of the pinch points that we're finding as a council. Again, that reflects national challenges and pressures. Where people, particularly carers, are seeking support, members will see some of the other performance indicators that provide some reassurance, I hope, that we're still continuing to work very well with carers, largely through the Carers First provider that we commission. Whether we can do more, I think is a moot point. Much of that respite care would be provided in residential settings, which in itself is limited, largely because of the current concerns around transmission.
Thank you. Okay. Karen?
Thanks, Chair. I'd echo the comments about the health checks being really important, because preventative healthcare is important, as are smoking cessation. But I would argue, and I know this is personal, but I'm making the point, if people can't access their GP for basic appointments, then you do wonder what the point is. Well, not what the point is, but, you know, it should be a given. And I know today, it's very rare that I use my GP. And today, I could not access them via phone. I really couldn't. They were not, and they were cutting you off. That was for an hour. And, you know, somebody elderly or with mental health problems wouldn't have had the dogged determination that I had to get through. And I actually drove down here and went over the road and went in the surgery, which we're told not to do. But if they don't answer the phone, what else do you do? And my point is, Is this monitored, this kind of thing, when people can't get through to the GP? Because this looks really good on paper. Everyone's going to get a health check and everyone can have smoking cessation support. But if you can't actually get to your GP for a basic appointment, you know, what's the answer to that? And is that monitored? Because I'd like to know that it is, but I bet it's not, because I don't see how they could monitor, because I couldn't get through, and I couldn't get through on e-console. I tried. It said that what I was describing, I needed to speak to someone. So how many other people does this happen to? If on the one very rare occasion that I tried to access a GP, a very good GP, I have to say, I couldn't do that. Thank you.
Thank you, Chair. That data, to my knowledge, isn't kept by the NHS. It is largely NHS data. So the performance report that you have before you today are those measures which, as it were, cover my area of responsibility. GP appointments and missed calls and missed appointments, we know is a national concern, not just in Lincolnshire, but in Lincolnshire as well. GP recruitment figures have not kept pace with demand. Some of that is structural in terms of training places. I do know that there's been some national reporting recently, not just on what is coming through the national bodies, like some of the charities like Age UK, where people have got growing concern that the consequence of not being able to talk to your GP means that people are going elsewhere, such as A&E, which isn't the best response, and putting pressure on hospitals. But some people aren't just taking any further action and are then struggling to cope at home. Of course, we're starting to see some of the consequences of people not being able to get to their GP. We also know that the result of COVID is that the NHS hasn't been doing some of the other things it should do ordinarily, and that is driving up acuity in patients. So people are becoming more complicated. I suppose what I'm describing is a vicious circle.
Yeah.
It's also one of the reasons
it's delayed, isn't it? And then it's early prevention is failing because we can't get to early prevention status. But I think also
through you, Chair, that was my point. It wasn't a criticism, but you just think this is really good stuff and it's the icing on the cake. But if we can't get the basic stuff right, like people being able to get to a GP who need to regularly, you know, this is, I don't mean it's an irrelevance.
In theory, you shouldn't be ringing your GP for a health check. A letter should have come out, asked you to ring up and make an appointment with the nurse or whoever is the person that does it. In theory, you shouldn't be held up because you shouldn't be seeing your GP to have a health check. It should be done by...
It's not in silos, though. My point is this is part of a bigger picture. Thank you.
I've got... Go on. Yeah.
Thank you, Chair. So it wouldn't be the first time that the chair of one scrutiny committee has spoken to the health scrutiny chair about areas for their investigation, and this would be a legitimate route for that.
I'd appreciate that if we could note that, because honestly...
I have actually just said to
Simon... if it was someone less bloody minded than I am, you'd have given up, you really would, and it's so rare that I try. And they're a really good GP, and I do all the preventative stuff like the flu jab and everything else, you know. But the basic stuff's falling.
I've got all the sympathy with you on this, but I've been there myself. But I think I have just spoken to Simon, actually, and we'll have a word at the end on the matter. Andrew?
Yeah, I was just going to add to that. My doctors are in Heckington. They're a very good surgery, and they've been promoting the Ask My GP thing, and I've used that several times through the pandemic and had excellent service. And I know not everybody has access to that, but it certainly must free up more time for people that have to ring to do so, because that has worked really well in our area. Thank you.
Can I just say, though, it threw me off that this morning, because you've got to fit into a certain box. Then you get to the end and it'll say, well, actually, we can't advise you over e-console. You need to ring. And you just go round in circles.
Well, I must have been lucky with what I wanted to ask them, but they were very good. They rang me back within a really short time, so thank you.
All right, well, I think general consensus is that as much as I'll have to no doubt report to Overview and Scrutiny Management Board about some of these indicators, but as we well know, COVID's had a huge impact, and you know, and I think some of them we will adapt to and change, and others will sort themselves out as we go forward next year. But at least we're aware of what our pressures are and adapt accordingly. So, Marianne?
May I just highlight the, if I might just highlight the carers support? I know it's been mentioned and the point about the financial assessments, but when you think how important that is, I was stopped in the street recently by somebody who is a full-time carer for a person with a lot of difficulties and with no help, 24 hours a day, all the way through COVID, jolly difficult. Thank you.
Brilliant. Okie doke. Right. Well, thank you very much for that, Caroline, wherever you've gone. And if you're still
Thank
there.
you, Chairman.
And okay, so Simon, over to you then, the work programme.
Thank you, Chairman. If I can just ask the committee to look at page 91 for the items for January and February. I'll just limit to the confirmed changes. On the February agenda, there will be another section. We're anticipating another section 75 pre-decision item on learning disability, in addition to the one there on mental health. There are several other strands that have been mentioned this morning, such as the social care reform white paper. There's also the social isolation, and those items will be looking to programme in consultation, obviously, with the chairman. Thank you.
So, okay. Well, thank you, Glenn, as well, for your support today. The care white paper. What we're anticipating doing in January is put it as a training session after the meeting. So what we'll propose is we'll finish the meeting, hopefully Democratic Services or whoever is on the case will organise a light buffet so we can have half an hour and then we'll go straight on into the training. And it will be about the white paper. Then the proposal is that following that, and we'll send the white paper, Simon will send the white paper when it arrives, so if anybody wants to read the detail of it and get right into it, then they're more than welcome. We'll have the training session, and if we feel that we want to address something specifically, then we will look for the February maybe agenda to put it on, rather than have the whole item as an agenda item. It might be something, because it is going to be a work in progress document, and therefore there might be something that we think actually we want to really raise back to legislation or something. So that will be the outcome after the training, what we then do. The social isolation strategy will be circulated, and again we will have a bit of a chat about that and decide whether we want to progress that as well as a working group when we've had a look. But I think if we get the information, then we can read it and digest it. It makes it a lot easier for us to then come and just discuss sometimes what we want to do, especially when we've got quite a lot of agenda items that have to come on and we can't delay those. So it just keeps the ball rolling along, because obviously next time round we've got the budget as well. So, okay. Andrew?
If I could just sort of add, I used to be a training manager, so I'm keen on the training, and I've suggested that we have a training session every other meeting, so not every month, but have one every other. So maybe if members have got other things that they think might be useful for that, we could perhaps just be reported. Thank you.
Okay, right. You've just set everyone off now. Okay. Mike?
Yes, I noticed you'd made a few references to the points we'd raised, but you didn't mention the veterans angle that was discussed earlier on, or is that going to be a report from one of our officers?
Did you say a briefing paper? Which one?
Veterans.
Yeah, well, what we've said is for them to put when they send round the KPIs and all the info, they put a briefing note on about that, so that in effect, then we can look at that, and if we want to progress further or raise it, then we can do. So hopefully, if they sort of answer the questions, then it's all there. I've got Marianne, Karen, and then Nikki.
There might be big implications for the budget from that white paper that's just coming out shortly. So I don't know if you might want to think, I know it's Christmas and all that, but I don't know if you want to think about doing an extra meeting if you felt that was necessary. Because if we only discuss it after the budget, we won't really understand the implications of it on the budget. So it's just a thought.
What we're estimating is that we will have about potentially 2 to 3 months where it'll be in what they call, I suppose, so-called consultation period. Even though they're going to mention it today, the chances of it coming straight out today, I think, are quite slim. I suspect it'll just want polishing up, and then in effect it will be released. So I think that's why we think that the January the 12th, I think, is when we're meeting, isn't it? And therefore, to do a training session, that is the training session.
Yeah,
that's fine. It's purely the white paper. So as much as we're calling it a training session, it is just about the white paper.
That's great.
We'll all go through it, and if we want to then, if there's something that we feel needs to become a scrutiny item, it can do. Or if there's something that we feel that we want to write to the LGA or the government and actually say, we really don't think this is good for Lincolnshire, then we can do. Karen?
Thanks. I was going to just say, Chair, I appreciate different people have got different commitments entirely, but I don't mind doing training whenever, as long as we've got a heads up and we can have a break before, in the middle of a long day. I find it easier to do a lot in one day than to try and field extra days in. Do you know what I mean?
I think it's just when we're all coming here on the 12th, hopefully, we get some sandwiches brought in, quick half an hour, carry on, and it just saves all the sort of everyone's travelling and every other bit. So
sorry, there was one other bit. Was the integrated care papers also coming out? So there'll be two papers. Thanks.
Yeah. So Nikki.
Thank you, Chair. Yeah, because of all of this and these meetings and the huge amount of information that we're having to take on board, I've actually sought out some training for myself around vulnerable adults, vulnerable adults, how to spot them, because very often, we get all our brilliant training when we first become counsellors, and it's absolutely fantastic, and the officers put so much work into that, and it's so valuable, especially when you've made notes and you can refer back to it. However, when you come to the scrutiny meetings, it's massive amount of information to take on board. So I found that when I was working, and you come back to the simpler tasks of casework, I could often be thrown into a situation with a vulnerable adult, too late to recognise this is a vulnerable adult, because you're behind the door, because they've contacted you about something, and then you realise there's a complex need going on there, and you're out of your depth. So I found that several times in the last 6 months, which was quite alarming for me. And I was beginning to think, gosh, is this because of the social housing issue, where lots of people with complex issues have all kind of got into one place? And so I'm finding I'm having difficulty in that, and so had to seek extra help for myself. Yeah. So you can do it, and there is stuff online actually that we do provide.
There is, and I will just say though, if you do want just one-to-one, all the officers are generally just email them and make contact. And if you don't understand something, just make contact, and they'll do a Teams meeting. I mean, when I first started, I used to walk round the Orchard House, and that was always beneficial. You just have a chat, find out what they do. They like it because they get the counsellor engagement. We can't obviously do that at the minute very well, but you can use Teams as well. So, but like you say, there's a lot of information out there as well. So, in fact, YouTube's often a good point, and we often never think about it. But it's amazing what sort of people will even post on that. So, okay, right. Well, thank you all, and we'll.